السلام عليكم. احنا just less than few minutes وبعدين نبدأ إن شاء الله بإذن الله. السلام عليكم ورحمة الله. مساء الخير الجميع. This is Osama Khan. I'm a consultant pulmonologist, and I'm honored to be here with you today to talk about CDI or clinical documentation improvement. قبل ما نبدأ في أحد ما يتكلم عربي. Does anyone of you who does not understand, does not speak Arabic? طيب. Before we go, first of all, هذا الكورس كان مترتب عن طريق كوسكو. الأوبجكتيفز كانت تقريبا almost 30 points، 30 نقطة. احنا دمجنا نفس المواضيع في تقريبا 12 إلى 13 points، بس كل الأوبجكتيفز راح تكون مشمولة فيها. فأنا راح أتكلم في اليوم الأول أغلبه عن الكلينيكال documentation from clinical point of view. most likely حيكون theoretical مع multiple examples على المواضيع اللي نتكلم عليها. بكره ان شاء الله حتكون الاستاذه مروج راح تتكلم عن البارتس اللي هو الخاص بالكودينج، حيكون لها اليوم الثاني بالكامل. just before we start احتاج اذا تكرمتوا everyone just mentioned your specialty or your field. اذا كنت انت تشتغل في السي دي اي في الكواليتي، اذا كنت فيزيشن تشتغل سي دي اي، او مجرد اي شيء خارج النطاق هذا، بس عشان نعرف الباك جراوند في الاودينس. ممكن تكتب في الشات بوكس، او you can just open المايك وتوك اذا كان مسموح. اخ صالح الله يحييك، اهلا وسهلا. البقيه اذا تكرمتم بس على السريع، على اساس نحتاج يعني نكون فاميليار مع الباك جراوند، على اساس الدسكشن يكون سموث فور ايفري. طبعا لان هو التارجت اودينس كان التارجت اودينس كان عام يعني للجميع، يشمل اي احد. everyone was welcome to attend. فبالتالي احنا حاولنا قدر الامكان انه يكون جنرال، يبدا من البيزك وبعد كذا نغطي قدر المستطاع من المواضيع بما فيها اكزامبلز على الديلي براكتس، وبكره ان شاء الله يكون مور سبيشلايزد بخصوص الكودينج. هي تنفع لكل التخصصات، بس انا احتاج اعرف على اساس انه اثناء الدسكشن او البرزنتيشن اكون عارف الباك جراوند، يعني ما اكون بتكلم ديب اكثر او يكون مور بيزك، بس هذه الفكره. بس هي تنفع لكل التخصصات طبعا، وهي مجهز على هذا الاساس. طيب ممتاز. اوكي انا will review your messages later بخصوص السبيشالتي بعد الانترودكشن. So just we'll start now. So as we said, we have more than 30 topics to talk about. Just we summarize it from the point of the objective to be 12 or 13 points, starting from key principles of clinical documentation improvement, the purpose of improvement, the purpose and improvement of accurate medical documentation, labeling the various components of a complete medical record vital patient information using appropriate documentation tools, importance of real-time documentation, mobile documentation tools, use of improper abbreviation, copy-paste errors, describe the role of clinical documentation improvement specialists in healthcare, translate medical jargon into easily understandable language in documentation, addressing physician arrogance in healthcare setting, and finally strategies for CDI specialists to educate and collaborate with physicians. بالنسبة للcoding, this will be tomorrow. Ms. Nuruj, she will be with you, and she will talk about her objective tomorrow, inshallah. So clinical documentation is the creation of a handwritten or digital record detailing medical information, progress notes, events, complications, clinical tests, treatment, or even medical trial. Clinical documentation serves as a backbone of a patient care, playing a vital role in ensuring accurate diagnosis, treatment, and continuity of care. طبعا الكلينيكال دوكيومنتيشن امبروفمنت اللي هو السي دي اي سبيشالست او السي دي اي تيم عاده يتكون من اكثر من تيم. عندنا الانفورماتكس، عندنا او الميديكال ريكوردز، عندنا البيشنت افيرز، الكواليتي، بالاضافه الى الميديكال ادمنستريشن. طبعا حتى الميديكال ادمنستريشن including معهم النيرسز of course. So clinical documentation used to facilitate inter-provider communication, allow evidence-based healthcare system to automate decision, provide evidence for legal record, and create patient registry functions. So public health agency, they can manage, they can research large patient population in more and efficient way. Remember the golden rules in clinical documentation. If it is not documented, then it was not performed. Reviewers do not know the services provided if there is no documentation. You are paid for what you document, not what you did. Document, document, document. More is always better when it comes to documentation. And as they said before, verba volant, scripta manent. This is a Latin proverb which translates as spoken word flies away while written word remains. So this is just to state the importance of clinical documentation. It's not what are you doing in clinical practice, but clinical documentation just to keep everything clinically from administration point and even legal point all intact. So our first objective today is the key principles of clinical documentation. Our focus on will be in enhancing the quality, accuracy of healthcare record. This is an important topic, as accurate documentation, as we said, is essential for patient safety, effective treatment, and healthcare compliance. Key principles of clinical documentation improvement, including, as we see, accuracy, completeness, timeliness, and compliance. You will hear this in multiple ways, like 5 C's principles or 4 C's principle, and even 10 C's principle, etc. But the idea is the same. So we have accuracy, completeness, timeliness, and compliance. This is another way, which is the 5C, pointing to clarity, consciousness, completeness, confidentiality, and chronological order. So principle number 1, which is, as you said, accuracy. First, let's talk about accuracy. Accurate documentation means recording patient information correctly, without errors, without any omissions. This is important because inaccurate documentation can lead to misdiagnosis, can lead to incorrect treatment, and ultimately harm to the patient. So let's take an example. If you are still using paper medical record at your center, with doctors still using handwritten for notes, orders, and prescription, so this is what you get. This is the result. A total mess, as you can see. Even if the nurses and pharmacists have the superpower to read this, but this is not normal, and this should not be justified by busy service or any other reason. So a sloppy written prescription can be misread or dosage wrongly interpreted. So this is a disaster for the patients. About this, in 2001, a British paper reported that more than 10% of handwritten prescription contained errors, while in USA, at maybe 10 years ago, have found that 20% of prescription were unreadable or readable only with efforts. There is another source, it's called NASIM, or National Academic of Science Institute of Medicine in United States. They said that doctors wrote about 3.2 billion prescription in 1 year. But poor handwritten on such notes leads to about 7,000 deaths and more than 1.5 million medical errors. So based on reports, doctors' script notes were meant to keep personal record of patient medical history and were generally seen only the doctor. However, with dozens of other professionals, they have to work together. Doctor, they are not alone in the service. طبعا الفكرة كلها أن جزء من الموضوع غير أن يكون busy service مع الفيزيشنز، هم في اعتقاد انه خلاص يعني this is between us، احنا الفيزيشنز مع النيرسز مع الفارماسيست نحن نقدر نفهم بعض and I can write in this way، هم راح يتفهموا الموضوع. But this is not productive, this is not the way it's going. في other departments، في الانفورماتكس او الريكوردز او الميديكال administration, assistant, quality, and even the patients. Sometimes they want to read the notes and discharge summary by themselves. So considering this way of writing notes is not productive at all and should not be accepted as normal behavior. So in BMJ, which is the British Medical Journal, a peer-reviewed research journal, they mentioned that handwritten medical notes were called dinosaurs of long overdue for extinction. So the journal, they mentioned this in around 2005, that there is surgeons audited the legibility of more than 40 randomly selected operative notes, and from the orthopedic section in a large British hospital. And what they found and published in BMJ, which is British Medical Journals, that by 2 nurses, 2 physiotherapists, and 2 medical doctors were rated the legibility of the notes as even excellent, good, fair, or poor. So their findings showed that only 24% were rated as excellent or good, and 37% they deem as poor handwriting documentation. So this is pointing up about the importance of handwriting if you are still using the handwriting. Many other centers, they are using both, like electronic and handwriting, and many other they shifted completely to electronic system. So admitting the possibility or of the unreadable doctor's prescription, they can cause harm, including death. Given the number of deaths reported to have been in US alone, several millions lives they are considered harmed by poor handwriting. And illegible handwriting can delay the treatment. They can delay the management plan. They can lead to unnecessary extending length of stay in the hospital. This will affect the patient flow and lead to more tests and more investigations. Sometimes doctors get like overwhelmed by patient complaint and would like just to scrap prescription to possibly dismiss the person. But getting overwhelmed is not an excuse. يعني إذا كان السيرفيس busy ما هو أبدا مبرر إنك أنت تستخدم هذا الهاند as we said. سواء كان المسكوميونيكيشن اللي يصير بين الستاف، سواء كان البيشنت هارمز، حتى الدث اللي ذكرناه قبل شوي، بالإضافة إنه حتى الكواليتي تتأثر، البيشنت فلو يتأثر، فبالتالي there is no excuse at all. And remember the basics of medical ethics: do no harm your patient. And unfortunately, this most often done in a governmental hospital worldwide, not only in our country, but in private practice is usually more difficult because they are just considering reputation in this manner. But overall, worldwide, the government is more than private sectors. So as a patient, if you are giving a prescription that is difficult to understand, there is nothing wrong to seek clarification in this manner. Meanwhile, there is several medical centers have embraced electronic documentation and printed doctor prescription considering as a safer option. And it's not only provide clarity, but also constitute as like a database of your information, a database of patient records. For example, medication records that patient has taken for years will be available if you have electronic system, but in paper documentation, this is usually a difficult situation. So with e-prescription, as we said, it's considered as a safer option. It saves life, it gives clarity, accuracy, and a database for your information. But do you think the e-prescription, the electronic prescription, is 100% safe? So this study was published in a pharmaceutical journal about prescribing errors before and after implementing the electronic prescription. So the way they undertook a before and after study. They compared the prescribing error in a hospital section, a study period using a handwritten prescription chart and preceded by implementation of a full inpatient computerized order entries. So a pharmacist logged all errors they identify and panel a pharmacist and doctor. They assessed any harm and they compared between the first before and after and the prescription between paper and electronic. So what is the result here? The result, they reviewed more than or around 183 handwritten and 178 electronic prescribing error in the two study period. None of the computer entry error and only one handwritten error were judged as having the potential for serious harm, while there was 2% and 8% respectively had potential for moderate harm. 2% moderate harm in electronic prescription and 8% in paperwork, paper handwritten. Overall, the average harm was 11% lower with electronic prescribing. So as a conclusion, a computerized system for prescribing inpatient medicine decreased the potential for harm to patient, although error was still made, but error identified during the study had a low average harm score, which was lower in the electronic prescribing. So the message is there is a lower harm with electronic prescription, but still harm of prescription errors still happen. This is the message for anyone who's working in CDI, that even with e-prescription, still it is not 100% safe. It will do better than the paper prescription, but with e-prescription should take a consideration by CDI team, medical records, and in a quality project in the hospital. So this is another example of the accurate documentation in a patient allergy or documenting the patient allergy, which is to prevent administration of any harmful medication. In this picture, you can see that the appropriate place, there is a dedicated place to document allergy in the electronic system. So in many healthcare facilities, they make this as mandatory. It's based on the hospital. So you can change this feature from optional in the electronic system to be a mandatory, which means you cannot go to the next step before you choose either, you cannot skip either you choose no allergy or you can add allergy. With further specification in this, you can specify the ingredient, what is the medication that caused allergy, and severity of the allergic reaction, and the type of allergic reaction happens. Like if the patient had respiratory symptoms or only minimal skin rash or severe swelling, etc. But what if you have like paperwork? What if it is not mandatory? In the previous one here, you can see this is a mandatory. You have like items you choose, and you cannot skip without this. Just take a look at this one. The doctor here, he just decided that he will write the allergy in the progress notes, not in allergies. There is no a mandatory option. So he chose to skip the allergy in the specific area. And in the progress note, he wrote everything about the patient, included in the bottom that the patient has allergy to something, whatever. So let's say the patient, the physician, he documented that the patient has allergy to penicillin in clinical notes, like you see in the picture. So do you think over time, with many other notes written after that, the following physician, they will notice that there is a patient, that this patient has allergy to penicillin? This will be easily missed, because the following doctor, he will come to write in another new progress note, and the next one will come to write another progress note. No one will notice that the allergy area was skipped, and here the penicillin can be prescribed easily, and patient can have allergic reaction. So the key principle number 2, which is the completeness. So complete documentation include all relevant information about the patient, covering their medical history, current medication or current condition, treatment, and any follow-up action. And a comprehensive record are vital here, providing that full care and ensuring that all healthcare providers that involved in patient care, they have the access to full picture. So as we said, it's not only about the physician. This is a teamwork, everyone playing a role in the patient care. Some expectation might be applicable in many centers, so to limit the access to some patient information. For example, some hospital, they have a detailed history about psychiatric patient, and those facility, they are limiting the access partially to only a specialized specialty like psychiatry for privacy of the patient. So including a thorough history of patient condition, including the guide treatment decision, even documenting a social determination of the health, which can impact the patient outcome and future plan. Let's say, for example, as we said, as you can see, the social history in the patient profile. Elderly patients who live alone at home. This is important part to be taken in consideration, as we can see documented this patient, this point about the patient living alone at home clearly and completely is important in patient care, as this patient cannot take care of himself or herself after discharge, and relevant team like social worker or even home care, they might have a different plan which could lead to a better outcome, because home care team can take care of this patient at home if he doesn't have anyone to take care of him there. So documenting this clearly in an appropriate place will change even the patient outcome. Okay, so key principle number 3, which is the timeliness of the documentation. Timely documented means recording a patient information immediately after the encounter of the procedure. This helps in maintaining up-to-date records, which are essential for making informed clinical decisions. Delayed documentation can lead to a gap between in patient care, and eventually will lead to error in the management care. So strategies to ensure the timeliness of patient care or patient documentation include deadlines and using some technologies that will assure streamline of the process. So let's take an example. In this picture, this is what we call endoscopy report. So for example, if a patient with suspected upper GI bleeding, he underwent to upper endoscopy, and then the doctor who did the procedure, he got busy with another case. So he delayed the post-procedure report and even the post-procedure orders. this which might happen frequently in our clinical practice. Then the primary team, who may be like internal medicine or general surgery or any other team. So the primary team, they will not be able to start the medication. The primary nurse will not be able to know the optimal time to resume feeding, and the discharge team or like bed management will not be able as well to manage the flow of the beds and discharge, etc. This is another example which using the voice recognition software, which can help to speed up the documentation. This is widely used technique and method by our colleague in radiology department. Many other hospitals, they are trying to implement this in everywhere, in all departments, including mainly the outpatient, because the time is limited. But currently in our country, most of the radiologists, they are using this. This are using by radiologists to speed up the process of the releasing reports and giving the opportunity of the primary team to have a faster response in patient care and according to the finding. So key principles number 4, which is compliance. Compliance is the 4th principle. Compliance refers to adhering to legal and regulatory standards for clinical documentation. This includes following guidelines set by healthcare authorities and ensuring patient confidentiality and data security. Non-compliance can result in legal issues and loss of accreditation. So the best practice to ensure that compliance is followed by regular training of the healthcare staff and implementation of a proper auditing system. For example, ensuring that all documentation meets the local standards like SIBAHI and GCI, with exposing all staff for proper frequent training and feedback, with conducting a regular auditing sessions. Sometimes you can do it randomly or to all profiles according to the capacity of your facility. This to identify the correct documentation issues. Without this, usually many hospitals, if you are not doing this on a regular basis, many hospitals will lose its compliance over time, and many deficient documentation will appear, and this will affect the medical legal part of your hospital, and eventually even the accreditation can be lost. So tools and technologies. Multiple tools and technologies can be leveraged. Electronic health record system and clinical documentation improvement software are instrumental in enhancing the accuracy, completeness, timeliness, and compliance of your clinical documentation. These technologies are providing structural template, automated data entry, and give you like a real-time alert if you have any missed data. As we said, an example of allergic history in electronic system. So after you write your clinical information, you cannot just submit it without having allergic history just completed. So as we said earlier, many healthcare facilities, they are still working on paper or not working on electronic system completely. With this method, the staff should work harder to be compliant with all documentation all the time. And always they have deficiencies in their documentation, despite they are trying to be compliant. And a lot of time and a lot of efforts are spent to assure that proper documentation by CDI team in the institution, and even by the clinical team themselves. This time better to be spent in patient care instead of just auditing paperwork. If the system is helping and implemented properly, this will help you just to focus more on your clinical part. But unfortunately, this leverage is not available to all medical centers. So this study, this was conducted in Germany and it published in the Journal of Medical Internet Research. It was about the value of electronic medical record for hospital care. The aim of this study, or the aim of this review, is to summarize the empirical studies about the value of electronic medical record for hospital. This was published between 2010 and 2019. As you can see in the result of this study, the majority of the studies stemmed from the United States. A total of 18 studies were analyzed, and EMR on the quality of healthcare. The effect of the efficiency of healthcare in around 70%. So from the primary data studied, 2 studies demonstrated a reduction of cost, and there was not only 1 study that failed to document the positive effect of quality of healthcare. So overall, 9 out of 16 respective studies, they showed a reduction in cost, about 56%, and 14 out of 18 studies showed an increase in healthcare quality. The remaining 4 studies missed the information about the proposed effect or proposed positive effect. So as a conclusion, the review revealed a clear evidence about the value of electronic medical record, in addition to also a majority of the economic advantages in the review. The review also showed improvement in quality of care by all respective studies. So the use of secondary data studies has prevailed over primary data studies in the meantime. So a future work could focus on specific aspect of the electronic record to guide their implementation and operation. Okay, so this is one of the ongoing issues in clinical practice and in clinical documentation, which is the VTE prophylaxis form, or the venous thromboembolism prophylaxis form. So if you are working in quality or in clinical auditing in a center with still working on paper system, you know how it is very easy and to miss this document. And many admitted patients have missed their VTE prophylaxis, and that increased the risk of in-hospital thrombosis that is completely preventable. You can prevent this event easily by implementing this documentation properly. And it is sad to have any case anywhere of in-hospital thrombosis due to improper or misdocumentation. Many hospitals, they are putting this form in the mandatory forms at time of admission. Like, you are collecting the most 7 to 10 important documentation. You are giving this to the admitting doctor at time of his receiving the patient from emergency. So one of the important documentation should be this form, which is the VTE prophylaxis, based on the patient risk, based on the patient situation. You have to specify the risk, or if the patient already on VTE treatment at home, you have to mention this clearly, so the patient will not be on double medication at time of admission. And if the patient has any limitation to use the medication, like bleeding or abnormal kidney function, you should specify this clearly and just follow the form. You will just reach and the result will be a proper VTE prophylaxis. Any hospital should have this with 100% performed. You should not accept to have less than that. Many hospitals, or many quality department, they have above 96, 97, or 98% as a KPI. But from clinical point of view, I believe this should be 100% compliance in the hospital. But this is, on the other hand, the VTE prophylaxis in electronic system. They have a feature of keeping this mandatory. So the same idea of having allergy history in the documentation, many hospitals, they are applying this as mandatory. many other hospitals, they have electronic system, but they are leaving this to the physician to do it or not. Then they are recording the compliance or the KPI for this. But from my point of view, I believe this should be completely mandatory. We should have 100% compliance, should not be less at all. So in this electronic system, you have a feature to keep this as mandatory process. So you cannot proceed to the next step without choosing either VTE medication, mechanical VTE, or no need for this VTE prophylaxis. This is, of course, a medical decision, but in CDI, quality or auditing, your role is to make sure this should not be missed at all. So training and education. Training and education are essential components of clinical documentation improvement, as healthcare provider must be trained in proper documentation practices and the use of technological tools. So if you have a dictation system, they should be properly trained about it. If you have electronic system, you should have more than one session, more than one time. It should be over a period of time to make sure the clinical or staff is completely trained about it. So effective training programs should cover all principles we have discussed before and provide even hands-on practice, not only a theoretical presentation. So this is an important aspect in training and education if you are working in medical records or healthcare informatics. So in many centers, they have a mandatory orientation for any new clinical staff. This including a proper training for the electronic record and the common documentation method. Unfortunately, many of these centers, they are just signing this paper for the new staff, so that he or she received the required training completely for the system and the important documentation without actual getting the training. This is unfortunate and happening a lot. Most of the center, they are doing this. So what will happen eventually? Definitely, many staff member will not be familiar with the requirement. They will know just the minimum they can use in the documentation, but they are not familiar with all requirements. They are not familiar with their duties and responsibilities and regarding proper documentation. And of course, in the end, a culture of poor documentation will spread across the facility. This is a weak point, which is in the end, this is the responsibility of the quality or CDI person who is assigned to do the orientation on day one. So regardless of your intention to help this new employee, you want him to join his work fast, to just not to delay any process in the hirement. But you participated in this poor documentation culture. So should we stop after orientation? Absolutely no. Continuous education, ensure that staff stay updated on the latest guidelines and best practices about using the documentation or the process. Mainly, if you are using the electronic, this need a continuous and frequent session, especially if there is new feature. So regular workshop and session on new EHR functionalities can enhance documentation quality. For example, if the IT team, they have added a new feature that allows the physician to bring any radiology report to be added in clinical notes. So instead of reading the clinical note of the patient and you want to go to the radiology report, what most of the center they are doing, they are just going to another application, opening the radiology, and then put the patient number. You will review all the radiology, then you will choose the one you need to do it in this day. After that, you will just read it and you will copy this sometimes and use it in your clinical note. So let's say the IT, he just implements this to allow the physician to bring any radiology report to be added in the clinical notes in automated way with only one click. So the IT and CDI team, they prepared like a short video just explaining this feature in a very simple and effective way. Then they shared this with all healthcare providers' email. This should be done over multiple times because not all healthcare staff will be able to review this on spot. And sometimes some of the staff, they need more than one session. They are not familiar with technology. They are unable to be updated quickly. And sometimes they will just forget the process. So by sending this on multiple times over a period of time, you will just assuring that every time healthcare worker is following what you are implementing and everyone is updated. This is another scenario. Let's say a scenario-based training in a specific department. For example, a CDI team with patient affairs, they receive a multiple incidents that there was a delay in discharge the cases from daycare surgery. Daycare surgery, that you are admitting the patient in the morning and you are doing the procedure, then you will just observe the patient for a few hours, then you will discharge the patient home the same day. That's why they call it a daycare surgery. So the CDI or the bed management or whoever the responsible, they just noticed that there is a delay in discharging those patients, and many patients delay even to the next day. So what they are supposed to go home the same day. After investigation from your side, it was clear that the reason of the delay was from the surgeons themselves due to delay in writing the OR notes. After the surgery, the surgeon should write OR notes and post-OR orders that should be followed by the doctors in the ward or by the nursing team. So one of the options here is to enhance the training after their morning meeting, because in the morning meeting, most of the staff in that specific department is available there, including the head of departments. Now you are directing your point to a specific department because this problem related to one department, which is in this case the general surgery. So you decided to enhance or to arrange a training session with coordinating with the head of surgery. You explain the point and the impact of a delay in your report and the benefit that will be achieved if the note's not done on spot. So during the meeting and after you explain the point, you will be able to open or receive their inputs. So sometimes they have their own input about this problem. They have another issue that they want to solve. So you will be open in this way and receive many input and obstacles to discuss it with that department. And finally, to reach a mutual understanding for the problem in order to resolve this problem effectively even in the future. And this actually happens to many of us as physicians. We receive a request from many CDI members, including quality or medical records, patient affairs, whoever is involved in this process. So they will come in our meeting and just discuss one issue, and they will ask our opinion. Why do you think this problem happens? And then they will explain the process again. I believe you should follow this, and regarding this issue, you can do this and this. You will reach to a mutual agreement that even will be for the better of the patient and for the CDI project itself. So the next point is monitoring and evaluation. Monitoring and evaluation are important for ensuring that ongoing improvement of clinical documentation is going well. So continuous improvement should be a goal. With feedback loops are corrective, there should be a feedback loops and corrective actions implemented based on the evaluation and results. With regular audit and review help to identify areas for improvement and ensure the adherence of documentation standard. You can apply a KPI for evaluation, including like error rates, completeness score, and compliance rates. For example, to track the documentation error rates can highlight the training needs. This can apply the same as in our previous example. Let's say you had a KPI about the discharge duration after the procedure. So the KPI that after any day case surgery, the patient should be discharged within 4 hours. So how many of the cases that discharge within 4 hours after the procedure? So this will help you to highlight the problem, and even if you ask a meeting with the surgery department, you can know your objective. Though this can be directed, for example, to a specific department, and if there is a problem, or let's say the KPI was not appropriate, or there is an incident report received multiple times based on the observation from nursing, for example, or other medical departments. So again, we'll go the same example that we have a day case surgery. You, as a CDI, you notice that smoking history is missed in particular in day case surgery, because you are considering this as a simple cases, patients are stable, and not all documentation are completed 100%. So you notice that the smoking history is missed, especially in those patients. And after that, many incidents, let's say, happened after a day case surgery that there is a respiratory complications in smokers, for instance, who went for surgery in the day case. So what you can do is to enhance this from the CDI point of view. First, you can start a training session. You can apply the same idea that you did about the discharge plan after the surgery, or the post-OR report. You can apply, this is a one way to go, like effective method to lead to a mandatory or at least semi-mandatory method. You can apply this if you have electronic system. You can put this as a mandatory, especially in the day case surgery. If you are still working on paper documentation, you can just monitor by involvement other member staff, like admission team or nursing staff, or implementing a specific KPI for this with regular meeting and frequent meeting. You can just give this to the head of surgery, like, and after 30 days, the KPI to do the smoking history is 30%. So after 60 days, it's reached to up to 60%. Then after 3 months or 6 months, more than 80%. Let's say your target is 75%. So you can just follow with the concerned department about this, that the target is reached and the document is completed most of the time. Okay. Here is another real-world example of successful clinical documentation improvement initiative. Let's say cardiology clinic in a new private cardiac center, or in a center that they have their own goal to enhance its documentation completeness to result in a better, fast, and completed documentation for direct admission through the clinic for right heart cath. So the aim here to have more cardiac cath from the clinic. They want, as a private center, they want to increase the procedure. So how can you help as a CDI team, regardless of your department? What you can do is optimizing the documentation plan by having specific templates, including a checklist for all risk factors for MI, including chronic illnesses like lipid problems, family history of early cardiac events, and a rapid checklist for 10-year cardiovascular risk score, like what we call it ASCBD score. In addition to checklists for current symptoms, a common symptom of MI symptoms and signs, then a one click by the doctor to bring all the tests. The same as we said about the radiology, you can apply the same idea about the other related tests to myocardial infarction, like ECG, chest X-ray, and echo, cardiac enzyme, any other related investigation. With one click, you can just recall this and implement it in your template. So what will happen? What will happen if you are applying this to your patient or to your template? This will lead to shorten the time of documentation. So the doctor will just do the checklist, which is related to the main problem, which is MI or suspected MI, and you want to increase the cath. So that will shorten the time for the documentation. At the same time, you are keeping a good quality of procedure, and the doctor will focus more on clinical part rather than just taking more time in documentation. So with this informative and efficient way of documentation, the approval for the procedure by insurance, even by insurance company, this will be easier. The number of rejection will decrease eventually. And in the end, what you get from your project is to increase the number of procedure with high score in documentation completeness. And this, of course, will enhance even other departments in your center to do the same, to increase the culture of proper documentation. You can have an example of any department or any procedure to have a specific templates. So in your center, what you can do, you can go to the clinic and choose the most 10 busy service, and you can apply 10 templates. Every template is directed to a specific service like this one, and your goal was to have more cardiac cath. So what you can do to help, as we said here in the example. Okay, so common challenges in CDI. While the benefits of clinical documentation improvement are clear, there are also challenges to be addressed. And common challenges include resistance to change. If you are working in a hospital with paperwork, you will face this problem even more frequent. Many people that once you are applying any new projects or any new form that should help the healthcare system or the clinical documentation part, you will find a resistance to change. And the other problem is the lack of resources to have. If you are suggesting a project to have like our previous example with your paperwork system, you will not be able to have the same. You will not have the same result. If you have electronic system and you want to do increased number in cardiac cath with the previous features, this will help you a lot to reach your goal. But if you don't have it at all, or you have it but with limited number of the IT team, for example, so lack of resources will affect your project in CDI. And of course, time constraints. This is the first answer you will receive from the doctors or nurses about the documentation. Why you are not documented in a proper way? The first thing they will tell you, we have a busy service and we don't have time to do this. So, however, this can be overcome by strategic planning, effective and continuous education and educational sessions. As we said in general surgery department, you can do this in all the hospital departments with more frequent sessions. The aim of the frequent sessions is to keep reminding the people. Many people, they are just losing compliance over time, and they just need a reminder. They just need someone to tell them you have to do this. And we are observing, we are reporting to the hospital administration. You have to keep everything as we did before, with high score of compliance. And one of the important points that will help in your challenges as CDI specialist, to have a leadership support, a strong leadership support. So leadership there plays an important role in spreading a culture of documentation excellence. It will ensure that adequacy of resources are allocated, and all CDI initiatives they have the support to follow with their plan. For example, securing or funding a CDI technology, whatever the technology, if it is electronic system or as we said, the dictation devices, whatever the resources you want. This is one of the things they want. You want a leadership support. But one of the other leadership support you need as CDI specialist, to address the resources constraint and to have an impact on doctors and physicians to be compliant with your instructions. So another strategy is to involve clinicians and nurses in the development of documentation policies to reduce the resistance, because they are the major players in the process of proper documentation. And this is happening actually in many centers. There is a CDI team, CDI project. They have a clinical documentation improvement team, starting from the top of the administration of the hospital, including medical administration, nursing administration, and of course the concerned department from quality and like medical record or medical informatics. So it should be a teamwork, and one alone cannot be compliant with this. We cannot go or proceed with the project alone without the other support. So I think before we go to the next objective, and I need, if any one of you have any comment or question or any example or experience from your experience as a CDI or as informatics or even as from medical administration, nursing, if you have any example you want to share or any comment, so we can just discuss this, and then we'll have a break before we proceed to the next. You can write in the chat. Anna, can you try to use your mic? I'm not sure if you are allowed, but I prefer if you can just افتح المايك وأعطي you can give us your experience. في أحد عنده أي نقطة أو أي point he wants to clarify or he wants to share any point? طيب إذا كان في any point you want to address, just you can write it in your note or you can write in the chat. We'll get back later on in the end of the day or in the end of the next session. أنا أعتقد إيش رأيكم إذا ناخذ بريك للصلاة، واللي حاب بس يريح لأن الساعة 5:05 إذا تحبوا، ونكمل الباقي. إحنا تقريبا قطعنا 30%. طبعا حسب الأوبجكتيف إحنا نقدر نخلص في 3 ساعات ممكن إلى 4 ساعات، لكن الأوبجكتيف وعدد الساعات CMEs hours وعدد ساعات المحاضرة هي جايتنا من الهيئة بشكل مباشر. إحنا we have to be compliant with that. فبالتالي حنقسمها، إذا مشينا أسرع نحدث يعني نزود البريك، وإذا أخذنا وقت في الدسكشن فيصير ناخذ بريك أقل. أنا أفضل إذا كان أي حد في الفيوتشر دسكشن يكون في participation from your side، خصوصا يعني أنا عارف إن مشكلة الدوكيومنتيشن هذه يعني a big dilemma in all hospitals. في دائما حتى الأفضل المستشفيات عندهم دائما مشاكل. always there is an areas of improvement. فعلى أساس يكون في فائدة للجميع ممكن نتناقش فيها مع بعض. فالساعة كم تفضلوا نرجع؟ 5 مناسب؟ 5 ولا 5:30؟ مين في أحد بيسأل سؤال؟ أخت سلمى. شوف نحن أخذنا الساعة 5، ترى في حيكون another break عشان المغرب والعشاء يكون أطول، فنرجع الساعة 5 وناخذ another على الساعة 6:15 أو 6:30 عشان صلاة المغرب للجميع. تمام؟ طيب ايش التخصصات المسؤولة عن الCDI؟ طبعا هي الCDI مينلي طبعا اللي يشتغلوا عليها في الميديكال ريكوردز، وفي مسميات جديده لها، الملفات الطبيه، التقارير، بعضهم اللي هو الانفورماتكس، حسب المسمى الموجود. هذول اغلب موظفين يكونوا فيها، لكن كبروجكت لازم يكون ابدا من مدير المستشفى الى كل الموظفين. عاده يكون في كوميتي يسموها CDI كوميتي، تمام. عاده حتى مطلوبه من اداره المستشفى انها دائما تكون موجوده، تتسوى بشكل دوري. الكوميتي هذه عاده تكون يعني الهيد يكون فيها الميديكال دايركتور، ويشارك فيها نسموها تشامبيونز من اكثر من تخصص، خصوصا التخصصات اللي فيها مور دوكيومنتيشن، مثلا واحد من السيرجري، واحد من الانترنال ميديسن، ويختاروا تخصصين ثلاثه او اكثر. يكون في عدد من النيرسينج حسب الاحتياج، بالاضافه طبعا لازم يكون في حمل الكواليتي اكثر من شخص، وطبعا اكيد التقارير او الملفات حسب المسمى الموجود في المستشفى. في الغالب هذه اغلب التخصصات اللي موجوده. فلازم يكون كوميتي، ويكون يعني متعدد التخصصات عشان تكون الفائده للجميع. آه، مشكله السي دي اي انه اذا كان فيها ليدرشيب سبورت او لا. اذا ما كان في ليدرشيب سبورت، هذه الكوميتيز تكون فقط مجرد ميتينجز روتينيه وما يتغير شيء. لانه زي ما قلنا طالما فيها متداخل عدة تخصصات، اذا ما كان فيها السبورت ما راح يكون فيها نجاح. عاده ايش اللي يصير؟ ليش الكواليتي هم اللي يكونوا انيشيتيف فيها؟ من ناحيه اللي هو الشكاوى اللي تجي الانسيدنت ريبورت. لازم انه مثلا النيرسز كتبوا ريبورت انه والله الدكتور اتاخر، بعدين سووا انفستيجيشن لقوا انه دائما الدكاتره يتاخروا في الموضوع هذا. فاذا لقوا شيء انسيدنت ريبورت متكرر في نقطه معينه، they will bring it to the meeting و they will discuss it بكل التفاصيل. طبعا المستشفيات اللي فيها الكترونيك سيستم لازم يكون في احد من الاي تي، حتى لانه احيانا بعض الحلول تكون انك تضيف فيتشر معينه، زي ما احنا تكلمنا مثلا في الالرجي والفي تي انك تخليها مانداتوري. هذا مين المسؤول عنها؟ طبعا الاي تي، هم اللي يعدلوا فيها وتكون الصيغه هذه مانداتوري. مثلا موضوع الكارديولوجي اللي قبل شوي تكلمنا عليه، انك انت كيف تصمم تمبلت مخصصه لهدف معين، لانه مثلا المستشفى هذا عندهم سنتر كبير او العدد البروسيجر اللي بتتم منخفض جدا، وانت عندك بروجكت مهم مثلا بياثر بشكل كبير على ميزانيه المستشفى الخاص اللي هو بيشتغل عليه. فبالتالي تحتاج الاي تي بالاضافه لكل التيمات اللي ذكرناها، لانه كل واحد يكون فيه انبوت خاص فيه. الريكوردز والانفورماتكس يحددوا الفورمز اللي يحتاجوها في السيستم كيف تتسوى. الدكاتره يحددوا احتياجاتهم من ناحيه طبيه، النيرسز يحددوا احتياجاتهم من ناحيه السيرفيس اللي يغطوها في العياده، وبالاضافه الى السيرفيس اللي يغطوها اثناء الكارديك كاث. فبالتالي هي مالتي تيم، لازم يكونوا وان تيم مع بعض. مو المفترض يكون تيم واحد، لان كذا انت خصصتها لتيم واحد، البروجكت هذا ما راح ينجح تماما. خلينا نقول مثلا انت قلت خلاص فقط الكواليتي هو اللي يمسك، تمام. البقيه راح يحضروا الميتنج فقط، يقول انا ما يكون عندهم انترست معين، ما يكون عندهم اي هدف انهم يحضروا، حتى لو حضر يكون مجرد وقت يضيعه ويكون اجتماع روتيني، و nothing will be changed in the future. طيب خلاص احنا نرجع الساعه 5 و10 وبعدين نحدد البريك اللي بعده لترى. اذا السؤال اللي هو نخلص الساعه 11، انا كنت اسال نفس السؤال، بس اعتقد نعم يعني عشان الكورس يعتمد لازم يخلص حسب الوقت المعتمد. لكن احنا النقاش حقنا مفترض ما يقعد لهذاك الوقت. احنا تقريبا خلصنا almost 25% لان هذا البيزك، بس بنمر على الاشياء الثانيه في الدسكشن اللي راح نمر عليها. فاعتقد الساعه 5 و10 نرجع جميعا ان شاء الله باذن الله. السلام عليكم. آه بس آخر شيء كان في سؤال في الشات من سل محمود، إذا هي موجودة بس خليها تكتب بالبوكس على أساس أجاوب على السؤال. طيب عموما احنا let's proceed with the part 2. إذا في أي سؤال ما تجاوب عليه بنتكلم عليه لاحقا. آه ممكن نكمل ساعة كذا لين وقت المغرب، بعدين ناخذ بريك again. إذا بنحاول نخلص قبل الوقت، لكن احنا we have to go back again على حول الساعة 11 لأنه هذا الوقت الرسمي لانتهاء الايفنت، فنخلي فقرة الأسئلة آخر شيء، بحيث أنه نرجع مثلا 10 دقائق نجاوب على الأسئلة والكونكلود الأكتيفيتي إن شاء الله. فإحنا let's go to the part 2. طيب احنا في البداية تكلمنا عن الكي برنسبلز في الكلينيكال دوكيومنتيشن. it was like an introduction للأشياء المهمة بشكل عام. نتكلم على كذا موضوع الآن بشكل تفصيلي أكثر. فالآن عندنا the purpose and importance of accurate medical documentation. Okay, so the primary purpose of medical documentation is to ensure continuity of care. Accurate record provide a comprehensive history of the patient health, and it enables a healthcare provider to make informed decision, and it also facilitates and communication among different healthcare providers. All the healthcare providers involved in patient care, it should ensuring that everyone is on the same page. This is a real life example. I know this story personally. This happened a few years ago. There was a doctor who used to work in a governmental hospital. He was in his 60s at that time. He was a very nice, polite, and with high productivity in his work. He used to see a lot of patients in the clinic as inpatient. He used to leave the hospital even after the working hours. He comes early in the morning. He was very productive. But there is one issue. So he used to cover a specialized clinic for years. Everything was perfect and everyone was happy. The nursing, the OPD staff, the patients, of course. But there was one issue. He doesn't write any notes in the EMR. That hospital used to be a paperwork hospital. So he used to write 2-3 words, then he will just conclude it. So this hospital shifted the work partially from paper system to electronic system. And that shift included the OPD. So one of the departments that shifted from a paper documentation was the clinics. So at that time, once they shifted from paper to electronic system, he didn't write any clinical note, not a single word at all. He used to know all his patients by heart. يعرفهم واحد واحد. لو جيته بعد 6 شهور بيتذكر الستوري اللي قلت له اياها في العياده بالتحديد، وبيتذكر الميديكيشنز كلها مع الجرعات مع كل شيء. So he memorized their own stories and clinical situation for years with no writing clinical notes at all. So once the patient comes into the clinic, he will just reply, hello, like Mr. X, I know that you have like Y disease and you are doing, how are you doing on Z medication I gave you a few months ago? He will just reassure the patient and renew or change the medication and then ask the patient to go home. So this doctor, he retired And the next doctor, he was hired like a few months later, who covered the same clinic after that. So the patient, the same patient who used to come with the first physician, so he used to come, they came again to the new clinic, and no clinical information at all. So logically, the new doctor, he started to ask the initial and very basic question from all over again. And the patient just will reply, why you are asking me this? I'm following here for years and all the information should be written. Just check the system. Why you are asking again? So the patient response, yeah, I think the patient response was logic and expected that everything is written. We just want to tell this doctor, yes, good job, but we appreciate your memory, but this is not helping at all. This is not the purpose of documentation. This will not assure any quality of care. So if we apply what we said on this clinical scenario, did the doctor, he ensured the quality of the continuity of care when we talk about his patient, his documentation? Definitely no. Did he facilitate the communication among healthcare providers? Definitely no. So it's your problem or your issue that you are memorizing the patient, but you are not writing a note for yourself. It is for everyone in the hospital. It's for the patient, for the healthcare system, for everyone. Did he support the clinical decision making for the following doctor? No. Did he enhance the patient's safety? Definitely no. Did he support any accurate diagnosis and treatment in the future? No. The new doctors has to start all over again. So the next is the legal and regulatory compliance. Compliance with healthcare laws and regulations is another aspect of medical documentation. Accurate records ensure the healthcare providers meet the legal requirements and protect patient privacy and even confidentiality. So non-compliance can lead to legal consequences, can lead to loss of accreditation like SIBAHI and JCI. Additionally, accurate documentation can serve as a defense in malpractice cases, providing a clear account of the patient, of the care provided to the patient. And in many malpractice lawsuits and cases involved the hospital staff or the hospital itself, it got lost, their lawsuit against the patient, and put themselves into a record of malpractice, while in fact they did everything right. But the problem was because of poor communication, of course. So, for example, if a patient with thrombosis, which medically requires to put a patient on anticoagulation treatment, at the same time, this patient has a major bleeding. So a treating physician, he discussed the risk and benefit with the patient and the family. Then he involved other teams, like, for example, hematology or neurology. Anyone has a concern on this patient, he involved this patient. No, he involved into this patient. So everyone agreed with other physician and the patient itself to continue on anticoagulation due to thrombosis risk. But what happened after that? The doctor himself, he did not document the MDT meeting. MDT is multidisciplinary discussion meeting that usually happens when you involve more than one team at the same table or bedside to discuss one issue. So after that, you have to document what happened for clinical benefit and medical legal. So the doctor, he did not document what happened and this problem. He did not write in the clinical note. He did not write in the patient and family education. He did not even inform the nurses in doctor's office. So the physician, he put himself in a situation to lose a lawsuit and to have a malpractice case in his record, while in fact he did everything right from the beginning. And why is that? Of course, due to poor documentation, of course. And by the way, this is not something uncommon. It happens frequently in our practice with a justification of a busy schedule and busy service. And of course, this has consequences like this. So challenges in maintaining accuracy. The first answer that you will receive it all the time about the time constraints. So maintaining accuracy in medical documentation can be challenging due to time constraint, due to complexity of patient cases itself. So healthcare providers often face a pressure to document quickly while maintaining and managing multiple tasks, including the patient care, patient decision, communication with others. Let's say, for example, the neurology clinic. You can imagine that a neurologist should assess a new neurology patient, including taking history, examining the patient, requesting investigations, and should enter all of this in the system. And all of this should happen in 15 minutes. This is crazy, of course. However, these challenges can be addressed through a proper training, use of technology, as we said, regular training sessions, and culture of awareness of documentation importance, and risk of deficient documentation, as we mentioned in the previous two examples, that even if you did it but you did not document, you will be jeopardizing yourself and put yourself at risk of malpractice case. So all of this can help staff understand the importance of accurate documentation. So we get back to our neurologist. How can we help them? That we know that neurology, new patients and new case, not a follow-up. If you have يعني مرضى الأعصاب عادة يكون عندهم يحتاج وقت طويل في العيادة خصوصا في أول زيارة. So how can you help this doctor in this case? عندنا مثلا اللي تكلمنا عليه موضوع الديكتيشن. Instead of spending time in typing during the clinic, you can just use the dictation. If it is expensive, you can use it in specific clinics where you have a delay in let's say clinical note entry. So you can use it, for example, neurology clinic, or if you have a senior doctor, he's more than 60, he's very slow in typing, you can use this dictation in those cases. Of course, there is a courses for fast typing. If you are in CDI project committee, I think it is logical just to suggest that we conduct courses for how to type faster. Maybe in the past, if we have this 10 years ago, I would accept that there is a senior doctors, even the middle-aged doctors or the clinical staff, that they have a slow typing. But nowadays, I think it's not accepted at all to have any person with slow typing as an excuse for the any deficient documentation. If you have this again, still you can suggest this by frequent or training, as we said, for fast typing courses. Another suggestion for this neurology is to have more than one doctor in the same clinic. Many healthcare facilities for education and for patient care and for proper documentation, they are doing this by having the consultant, who is the most responsible person, in addition to two other doctors, maybe two specialists or two residents, or one specialist and one resident. They are covering the two clinics, so they can just have a faster flow of the clinic. And the consultant, who is the most responsible, he's moving around between the two clinics, supervising that the plan is done on a perfect situation. So I think this is one of the great solutions for more than one reason. The challenges here for this suggestion is no enough space in the clinic. Sometimes you have a very limited space, so you cannot apply it to everyone. So the next objective is labeling the various components of complete medical records. So a complete medical record is the cornerstone of effective healthcare delivery. As we said multiple times, it ensures continuity of care, support clinical decision making, and helps in legal and regulatory compliance. In this objective, we will discuss the key components of medical record. This including patient identification information, medical history, progress notes, medication records, even laboratory and diagnostic tests, treatment plans, and two important forms, which are consent forms and discharge summaries. Each of these components plays a role in patient care and safety. So let's get started. So patient identification information is the first and fundamental component of medical record. This includes the patient's name, date of birth, address, contact information, etc. So accurate identification ensures that the healthcare provider is referring to the correct patient. For example, in a busy service or a busy hospital, like most of the hospitals, a mixing up patient identification can lead to administering a wrong medication or wrong treatment, or even applying a wrong procedure to a different patient, which could lead to a major medical problem by mixing up the treatment or management plan between two patients. Many clinical staff, they are taking this lightly, but once the disaster happens, then you will recognize the importance of this. So those mistakes are not uncommon. You should not just taking for the granted that nothing will happen. It might happen in any center, and taking the basic identification data lightly will definitely make this happen. Medical history. The medical history section provides a comprehensive overview of the patient's past medical conditions, past surgeries, allergies, and family medical history. This information is for understanding the patient health background and identifying the potential risk the risk factor for the patient. For example, if you are a treating physician and you know that this patient with past history of diabetes with chief complaint of erectile dysfunction, this is important to guide you in the proper investigation, diagnosis, and plan of care. Another example is documented a family history of heart disease or early death with cardiac events, which is support immediately early screening and preventive measures in those cases. A detailed allergy history, that we mentioned this example multiple times, can prevent serious reaction to medication or treatment. And as we said, this is one of the issues that I would suggest that should be mandatory to all, to every healthcare system, and should not be missed at all. So here is a complete picture where you can see a complete information about the patient medical surgical history, immunization, family history, and lifestyle. And here you can see in the middle, the doctor filled the allergies where it's found to be positive for penicillin and B. pollens. This is your option in your hospital to have it all as mandatory. I wouldn't suggest that at all, but you can take the most important that might affect the frequent cases, like allergy or management plan, diagnosis, and as we said, the VTE forms. You can choose based on your hospital statistics which forms or which items that can be mandatory and which just you will leave it for the treating clinical staff. So progress notes are the part of the medical record where healthcare professional record details to document the patient clinical status or achievement during the course of hospitalization or over the course of outpatient care. بالمختصر احنا عندنا شيء اسمه admission note على سبيل المثال. اذا patient تنوم يعني في البدايه المستشفى عن طريق الطوارئ او التنويم مباشره اللي هو الدايركت ادميشن. في عندنا شيء اسمه admission note، فهذا نكتب فيه كل التفاصيل الخاصه بالبيشنت، ابتداء من الباس ميديكال. طبعا نبدا بالايدنتيفيكيشن داتا في البدايه، بعدين الباس ميديكال هيستوري للبيشنت او ميديكال هيستوري كامل، والتشيف كومبلين، السيرجيكال والفاميلي هيستوري، بلاد ترانسفيوجن، اليرجيز، everything you will write it including الاكزامينيشن. بعدين نكتب الاسسمنت وش راح نسوي during الادمشن. لكن البروجرس نوت you will write it على الديلي بروجريشن اللي قاعد يصير. لان انت you admitted the patient for a reason, there is a cause for admission. So what happened after that? You applied a treatment plan. So what happened? What is happening every day for this patient? فانت تكتبها اما every day, every other day على حسب الكيس اللي موجود عندك. ونفس الشيء بالنسبه للعياده، you are following one patient for a reason، يعني over time. مثلا اذا قلنا you are following this patient عشان مثلا عنده heart disease ولا diabetes، ف you are following for one reason or multiple reasons، فانت تكتب في كل زياره every 2 months, every 6 months, every year what is happening, how is the patient is doing compared to the previous one. So a progress note are essential for ongoing documentation of patient care. They include daily hospital notes, outpatient visit summary, and details on the patient response to treatment. فإذا أنت بديت غيرت شيء في المانجمنت، الفولوينج نوت لازم تكتب إنه what happened مع البيشنت. أنت you started البيشنت على antibiotic، لازم تكتب what is happening. هل صار في فيبر ولا لا؟ هل البيشنت صار عنده reaction ولا لا؟ any side effect next day؟ هل البيشنت responding to your treatment ولا لا؟ فهذه should be done على progress note، يكون done على period of time comparing to the previous note أو compared to the situation بعد ما أنت بديت new treatment. So إذا كان in hospital setting, daily progress note tracks the patient recovery from a surgery, including any complications or improvement. While in an outpatient clinic, progress note document a follow-up visit and any changes in the patient condition or treatment plan. Another example is noting that the patient responding to a new treatment, which helps in adjusting doses or switching medication if the patient is not responding, or switching the patient if the patient develop any side effects, for example. So this is a review of a progress note. You starting by the date and time, then the service providing this note. In this case, it is a general pediatric progress note. After that, you just in summary you wrote a patient identification, then the diagnosis, a time of admission, or a problem list if the patient has more than one issue. And what is the ongoing treatment? Okay. After that, you will go we call it SOUP approach, which is subjective, objective, assessment, and plan. Subjective is to write the patient progress from the patient's point of view. In the patient in the patient specific words، يعني بنفس لغة البيشنت. تسأل how do you feel today؟ فهو he will reply. So you will document in the S area what is happening with the patient in the patient's own words. Right? Is he feeling better or not? Objective is the physician observation, or is the clinical staff observation clinically, including signs and investigation. Assessment is the final clinical staff judgment for what is going on with the patient، يعني المختصر your judgment على الكيس. Then the plan based on the above details. يعني in a summary, it's like subjective and objective. You are gathering information and do investigation. You are gathering information starting by the patient, then your own investigation. Assessment is the analysis and judgment, and finally the plan is your action. Medication records are critical component in a clinical documentation. They include details of all medication prescribed, including dosages, including administration schedule, and any adjustment made. It should be written accurately and in detail. You have to keep in mind the paper documentation or paper prescription versus electronic prescription, which we discussed earlier. So here is an example of electronic medication prescription. You can see all the details are available, including from the drug name, the strength, then how to take it, the duration and quality of the refill. And you can see down all the details related to the patient, the clinical problems, and history of allergy. And here is a bad example of medication form with a bad handwriting. And this should be avoided in any clinical practice. No excuse for this at all. Okay, now we move to an important form, which is the consent form. Consent form are legal documentation that record the patient agreement to a specific procedure, or even a treatment plan, or whatever. يعني كان يكون أحيانا يكون surgery، أحيانا يكون simple procedure، أحيانا يكون management plan أو يعني new medication. بعض الميديكيشن تحتاج consent حسب الكواليتي. So these forms are to ensure that the patient is informed about the risk, informed about the benefit, and informed about any other alternative before proceeding. For example, a surgical consent form is outlining the details of surgical procedure and any complication that might happen with signature before the surgery. Here is a review for a consent form for a procedure. You can see starting from the top where you have the hospital name and what is the name of the consent of the form. It is called informed consent for surgery. And to the right, as we said, the patient identification data. And the next will be the name of the doctor and then the patient, and was admitted on you will write the date. After necessary investigation and test be determined that the condition, you will write the diagnosis, and this will require you will write the procedure you will do. And in the middle, the surgical procedure, you will write the expected complications clearly. And then the next, just a statement that I, like the patient, I was informed about all of this, that this is my diagnosis and there is no alternative. This is we agreed on the procedure and the expected risk. I'm aware about it. Then you will write your name. There is a signature for the doctor. There is a signature for the patient with the witness. And if the patient is not able to sign, there is based on the policy in your hospital, there is another person will sign, and it should be documented, the relationship with the patient. Okay, an important aspect is the witness part and who will sign instead of the patient if the patient is unable to sign, as we said just earlier. So you should go back to the hospital and local policy and procedures. But the bottom line, don't take this lightly. You should not miss the witness part. You should not ask anyone to sign on behalf of the patient if the patient is conscious and eligible to sign. And always go back to policy procedure reference. So even if you are working in a CDI project and reviewed a consent form that is not signed of the patient, not signed by the patient himself or herself, and you reviewed the notes, the patient is awake, fully conscious, and he's not underage, you should notify this, and this should be discussed because this is even medically and medical legally, it has a complication and consequences. So next is the discharge summary. Discharge summaries are important for ensuring continuity of care after a patient is leaving the hospital. احنا تكلمنا على كل الفورمز اللي قبل، كل واحد له هدف معين. الادميشن نوت، ادميشن نوت اللي تكلمنا عنها تتكلم على السمري للكيس قبل التنويم، والان ايش المشكله الحاليه وايش راح نسوي الخطه اثناء التنويم. البروجرس نوت راح تكتب كل النوت during الادميشن day after day، وكل يوم تكتب البروجرس اللي بيصير سواء من البيشنت او من الفيزيشن او من اللابس وات ايفر، وكل يوم تحط your new assessment and plan. Now the discharge summary, the aim is to write انه يكون عندك continuity of care بعد ما يطلع المريض من المستشفى. Okay. So the discharge summary will summarize the reason of admission and the treatment plan received and condition at time of discharge and follow-up care instruction. I put an example here. A discharge summary for a patient treated for pneumonia would include details of condition at time of admission, the antibiotics administered, and the duration of antibiotic. If there is any side effect happened due to this antibiotic, if there is any allergic reactions done or happened at the first time when antibiotic given, and what was the patient response to treatment during the hospitalization, and any instruction for continuing care at home. Will you switch this antibiotic to oral or tablet, including the management, when to come to ER, and if there is any follow-up as outpatient in the clinic or not. So here you can see an example of discharge summary. Starting by the admission date, discharge date, and admission diagnosis, initial admission diagnosis, and if the diagnosis has been changed during the hospitalization due to your own investigation, and if there is any new input during hospitalization. Consult, you will add any consultation done to any specialties and what was the finding and recommendation. Procedures, you will write all the procedure, including mild or major surgeries done, minor or major surgeries. History of presenting illness, and then hospital course, which will summarize the progress notes you have written during the hospitalization. Discharge 2, you will specify if the patient will go home or he will go to another center or he will go to long-term facility, for example. Discharge condition, if he is stable or not. Discharge medication, you should include it all with details, the doses, frequency, length of therapy, and any changes to pre-existing medication. وهذه مهمة للبيشنتس اللي عندهم previous medication وانت غيرت مثلا doses للمedication هذه, you have to specify it clearly in the discharge form. Discharge instruction, list all instructions that were written on patient's discharge form. Pending labs, إذا كان في أي labs مثلا على سبيل المثال إذا patient دخل for investigation of cancer and you got a surgical biopsy. عادة العينة تاخذ وقت عشان يطلع result، فأنت you discharge the patient, you have to mention in the pending lab that there is a histopathology form, histopathology result is pending, it will be followed up in the clinic. Follow up, you have to mention the patient will follow up or not, and you have to specify the time and date. طيب احنا عندنا يعني في الاوبجكتيف هذا عندنا اللاست سلايد. احنا بنكتب كل يوم progress note، تمام. Let's say the patient he stayed in the hospital for 5 days. Why not I just copy the last progress note وخلاص اعتبرها هي discharge summary. Do you think this is okay or not? So if the doctor is writing daily progress note, why should I write a different discharge form? بس عشان كذا ازود الفورمز وخلاص. لازم يكون حتى الفيزيشن عندهم او الكلينيكال ستاف they are familiar why you are doing this. ليش عندك progress note and then you are asking them please write a discharge summary, another form. So should he or she, the clinical staff, just copy the last day of progress note and paste it in the discharge summary form? Of course, the answer is no. And why is that? Let's say this patient was admitted with appendicitis. So on day 1, he has a severe pain and vomiting. Then he went for surgery. On day 2, he has less pain, but he had a high blood pressure. This required, like, for example, internal medicine consultation. So they managed the case, and they documented that we need to follow him, to follow up in the clinic. On day 3, the pain improved, but he had a high blood sugar and hematuria. So the patient was referred to endocrine and urology team. So urology, they asked for blood culture and to follow up in the clinic. Therefore, patient had his labs and images all done. With dietitian review, he started to move around, mobilize slowly. On day 5, he was fully mobilizing, blood pressure was controlled, and then blood sugar was controlled, no more hematuria. So if the physician just relied on the last day of progress note, he will copy that and he will consider it as discharge summary. So then this discharge summary will be very deficient, lacking a lot of information. As we said, in day 2, patient had high blood pressure, day 3, high blood sugar, he had a positive blood in urine. So all of this information will not be involved. So you have to make sure, because many clinical staff, when they are asked that you forgot to write your discharge summary for this patient, what they are doing is just they are copying the last note of progress note and put it in the discharge summary, and this is very deficient and will not be helpful for the patient. So all data will not be mentioned in the discharge summary, and the patient, let's say the patient, he went to follow up in another center. He didn't come to your hospital. He went to another hospital with the discharge summary, which is only the last day progress note. So many medical information will not be missed. Some of the doctors and clinical staff on the progress note, they are writing all the details. يعني يخليها بطريقه تراكميه. في اليوم الاول يكتب بروجرس نوت، اليوم الثاني يكتب البروجرس نوت حق اليوم الاول مع التعديلات اليوم الثاني، يجي اليوم الثالث يكتب حق. هذه طريقه ممتازه، يعني ممكن you can do it. But many physicians and other clinical staff, they are not doing this. They are just every day they are writing a separate progress note, and based on this, on discharge summary, you have to go back on every day progress note and just extract the summary of each note separately and add it to the discharge summary. طيب انا اعتقد احنا بنوقف هنا ونشوف اذا عندكم any comments or experience or you have any questions. نحن will discuss it for 10 minutes. طيب هنا في سؤال how many diagnoses you can add in the discharge summary. طبعا هذا يختلف من فورم لاخر، بس كفكره اساسيه you can add more than one. عاده يكون عندك انت اللي هو البرنسبل diagnosis، وبعدين you can add another diagnosis. تمام. في البدايه يكون عندك working diagnosis، في التايم اوف ادميشن في الديscharge summary يكون عندك discharge diagnosis، بعدين you can add other comorbidities سواء كانت الاكتف او حتى الكرونيك سيتويشن للكيس. طبعا بكره الاخت مرود راح توضح لكم هذا بشكل افضل، لانه هذه لها تبعات اخرى غير الكلينيكال بارت، لها شغلات في موضوع الكودينج، موضوع الريمبرسمنت والبيلينج والامور هذه، فتحتاج تكون فيري اكيوريت فيها. بس من ناحيه كلينيكالي يس يو كان اد مور ذان ون، بس يكون في برنسبل دايجنوستس وي شود موديفاي حتى كل يوم. اللي يتعاملوا في مستشفيات خاصه يعرفوا هذه، انه sometimes حتى البزنس سنتر اللي عندك بيكلمك يقول لك معلش احنا عندنا ريفيوز ريجكشن او عندنا وات ايفر، نحتاج يكون تعدل هذه بالشكل الفلاني، الدياجنوستس هذا ما هو معتمد، فبالتالي يختلف من مكان للثاني، لكن في اساسيات نمشي عليها. Any other question? طيب سواء الاخت سلمى كانت موجوده ولا، احنا بنجاوب على السؤال اللي هي ذكرته في السكشن السابق. قالت احنا قسم فعال لكن ما حد ينظر الى التغيير اللي نسويه، للاسف في اشياء تضاف لنا عمل اضافي، مراقبه اداء الاطباء بتعبئه النموذج بنسبه 70%. هل السي دي اي مسؤول عن تعبئته؟ طيب الان السي دي اي كاسم مفترض انه يعتمد على اكثر من، يعني سي دي اي ان ايديا اكثر من انه قسم. ممكن يكون انت في سنتر معين تسوي سكشن او تيم خاص ديديكيتد للسي دي اي، اتس اوكي. بس في اغلب الاحيان يعني اللي يراقب يسوي المونيتور لعمليه الدوكيومنتيشن يكون في قسم الميديكال ريكورد. احيان كثيره القسم هذا يكون منفصل او يتبع قسم شؤون المرضى، او احيانا يعني يكون يعني في مستشفيات يدمجوا الاي تي مع الريكورد عشان السيستم عندهم كله الكترونيك. طبعا هذه تقسيمات اداريه تختلف من مكان للثاني، لكن الفكره انه يكون عندك انت الايديا. انت كسي دي اي اذا تقصد سي دي اي احنا الميديكال ريكوردز، لا مو مسؤوليه الميديكال ريكوردز ان هم يقوموا بتعبئه النماذج الخاصه بالاطباء. طبعا لذلك انا حطيت important slide انه الليدرشيب رولز از فيري امبورتنت. تمام. اذا لازم يكون في توازن معين، لانه في الاخير هذا will reflect الهوسبيتال في اشياء كثيره، سواء كان موضوع الاكريديتيشن للجي سي اي والسباهي، سواء كان للمال براكتس كيسز، لانه اذا كان في بور دوكيومنتيشن احيانا مو بس الفيزيشن اللي يكونوا انفولد، احيانا يكون حتى الهوسبيتال ادمنستريشن نفسها الرولز ما تكون واضحه من ناحيه الدوكيومنتيشن. وطبعا الشيء الثالث اللي هو الميديكال كير للبيشنت. فليش انا قلت انه عاده يكون في الكوميتي، والكوميتي هذه يكون مسؤول عنها الميديكال دايركتور. الميديكال دايركتور لانه يكون يتعاون فيها مع الميديكال ريكورد، ويكون هو المسؤول انه تو دو مور بريشر على الفيزيشنز انهم يسووها. احيانا يكون فيها المسؤول عنها النيرسز، اتس اوكي يعني ترى ما هو رول واحد يمشي. بس اذا ما كان تيم وورك والهوسبيتال دايركتور سبورتنج البروجكت كامل، ما راح يكون في تحسن، راح يكون في a lot of mistakes، راح يكون في a lot of inappropriate things happened. انك انت تكون في ميديكال ريكورد وتعبي عن الدكاتره شيء في الاخير حتى ميديكال ليجل، يعني في الاخير مسؤول عنه الدكتور، كيف انت تعبي عنه شيء يعني انت هو ما سواه؟ لانه في everything you are doing، اي شيء انت تعبيه ترى مفترض it reflects something. يعني انت لما تحط تك على شيء المفروض هذا الشيء انت فعلا سويته او لا. ف يا اتس ا بيج بروبلم صراحه اللي يصير احيانا. وزي ما قلنا ترى لما يكون المستشفى اتس ا بيبر سيستم، تحتاج عدد كبير من الستاف انك انت تراقب وتعدل وتضيف، وتحتاج حتى تفرغ اطباء احيانا عشان هم يساعدوا التيم اللي موجود في الريكوردز ان هم قاعدين. لانه يعني مثلا الريكورد هو يسوي مونيتورنج بس يحتاج احد يعدل، يضطر انه يكلم دكتور من كل قسم، تعال القسم حقكم عنده مثلا عدد 30 او 40 ملف فيها كثير من الديفشنسز نحتاج تتعدل. طبعا متى تطلع الامور هذه؟ تطلع اذا لما يقرب موضوع السباحه والجساي. This is not a good for continuity of care. This should be يعني should be done on frequent basis، مثلا كل شهر تسويها، مو والله كل سنتين لما يجي اللجنه حقت الاكريديتيشن بعدين تطلع الامور هذه. فيطلع عبء على الجميع وما يكون في فائده اصلا من الدوكيومنتيشن اللي احنا بنتكلم عليها من الاساس. فاتمنى الصوره تكون واضحه بالنسبه للسؤال اللي سألني. اخت ابرار تفضلي. ترى مو لازم يكون في الكتابي، يعني عادي ممكن تفتح المايك وتسال، ما في مشكله. طيب اذا كان في نقص في ملفات المرضى من ناحيه التوثيق، خلى المسؤول رئيس القسم. طبعا انا هذه الجزء من الجواب هو نفس السؤال اللي سالته سلمى، انه كيف يتم هذه لازم. لذلك لما يكون كوميتي في المستشفى دائما هو افضل طريقه لابروتش الامور هذه. لانه اذا كل قسم يشتغل بشكل منفصل، ما يعني تلقى الامور ضايعه بشكل كبير. يعني مو ضايعه انه والله ما حد يعرف ايش. يعني انت تيجي مثلا في الميديكال ريكوردز تلاقي الملفات هذه بعد الديسشارج، سواء كان تتكلم على اوبن بروفايل ولا كلوز بروفايل، سواء بيشنت موجود او خارج، في كل الاحوال اذا كان في اي ديفيشنسيز موجوده يصير الموضوع في بعض المستشفيات يقول لك خلاص اول شيء تواصل مع الدكتور. تمام. اذا تواصلت مع الدكتور يقول لك انا راح اجي ان شاء الله، تمر يومين 3 ايام 10 ايام وما يصير شيء. طيب ايش تسوي؟ كلم رئيس القسم. كلمت رئيس القسم، مر اسبوعين 3 ما صار شيء، تضطر تكلم ميديكال دايركتور. الميديكال دايركتور يرجع يكلمهم، بعدين يروح يسوي لك اياه. تخيل انت عشان كل ملف انت تمشي في اللوب هذا كامل. فبالتالي لما يكون في اما سي دي اي تيم ديديكيتد او يكون كوميتي تماما. الكوميتي ايش يعني كوميتي؟ لما يكون في موضوع سي دي اي، انت الان مثلا خلينا نقول السي دي اي كوميتي تشكلت وبتتجمع يعني بشكل دوري وبدون اي تاجيل. ليتس سي انهم قالوا خلاص كل يوم اول اربعاء من كل شهر خلاص حنسوي سي دي اي كوميتي ميتنج. الكوميتي هذا حيكون يجتمع مده 4 ساعات كل شهر. مين الهيد اوف كوميتي؟ او ميديكال دايركتور. تمام. وهي از ريبورتنج كل ميتنج، يعطيه للمدير المستشفى بالتقرير اللي صار في الميتنج. سو الميديكال دايركتور موجود مع عدد معين من رؤساء الاقسام والاطباء، موجود معاه مدير التمريض، موجود معاه اللي هو الميديكال ريكوردز، موجود معاه زي ما قلنا الاي تي والبيشنت افيرز. ممتاز. اوكي. الان يجي يستعرض العدد الملفات اللي ناقصه. مثلا الميديكال ريكوردز اللي موجود، انت مو بس انك انت تجيب عدد الملفات الناقصه، انت تقول انا عدد الملفات اللي ناقصه اغلبها مثلا 70% في شغله معينه، مثلا كانت الديجيتال سمري ما هي موجوده، او الفي تي اور ما هي الفي تي اور ما هو موجود. فاول شيء تقول الميديكال دايركتور يقول للموجودين انا احتاج رقم الملفات الان تترسل لي، ما نطلع من الميتنج الا ترسل لي كل الملفات الناقصه، وطبعا يكون موجود كل قسم من المسؤول عنها والدكتور وكل شيء. بنهايه الاجتماع هو ارسل لكل الاقسام انا احتاج هذه تتسوى في 24 ساعه. هذا نمبر 1. نمبر 2، ليتس سي ايش الستاتستيك اللي عندكم؟ ليش عندنا الفي تي او فورم؟ واي نوت انه الفي تي او فورم دائما فيها ديفشنسي؟ تمام. واي الدشار سمري فيها ديلي؟ فتجي لموضوع الفي تي او فورم، واحده من الاشياء الورقيه طبعا دائما فيها مشكله. فواحده من المستشفيات سوت طريقه انه جمعت 10 ملفات كان منها الفي تي او فورم. النيرس المسؤول عن الادمشن والنات سند البيشنت من الاي ار الى التنويم الا لما ال10 ملفات هذه تكون مكتمله. يقول طب والله انت يو ويل ديلي المانجمنت، حيتاخر المانجمنت حق البيشنت. اتس نوت ماي بروبلم، يو كان كومبليت المانجمنت الان بسرعه، واي تاخير في حركه المريض المسؤول عنها الدكتور. ليش ما كملت الملفات؟ فسوي لي الملفات هذه باقصى وقت الان تسويها. مشغول، ما انت مشغول، هذه ملفات ما تحرك المريض لما تسوي. في واحده من المستشفيات سواها وكانت ناجحه فعليا. طبعا في دائما اكسبشنز. اوكي اذا كان بيشنت لازم يروح الان على او ار، لازم بيشنت يروح الاي سي يو، هذه اكسبشن احنا ما نتكلم عنها. لكن لما يكون بشكل اعتيادي يو كان دو ات، انه بيشنت ما يتحرك الا 10 شغلات هذه اللي دائما فيها ديفشنسي ومهمه انها تتسوى. تمام. ف الملفات اللي موجوده اغلب الاحيان اذا مثلا طب كيف نكمل الملفات اثناء الشهر هذا؟ مو ما حستنى الميتنج لما يصير عشان نسويها لتكمل الجواب لسؤال ابرار. نعم. اغلب المستشفيات يقول لك خلاص ارسلها رئيس القسم كل اسبوعين او كل اسبوع وهو يكمل لك اياها. في بعض الاقسام خلاص يقول لك احنا نحط شامبيونز لكل شغله. يعني مثلا الديفشنسي اذا كانت حقت الديسشارج سمري والفي تي اي فورم، اختاروا دكتور من كل قسم يكون هو مسؤوليته انه القسم المعني يتواصل معه عشان يكملها. تمام. وفي بعض المستشفيات عندهم مشكله في الدث نوتس مثلا، يقوموا يحطوا احد معين يعني ديديكيتد مسؤول عن هذا الشيء. هذه تنفع في الاقسام الكبيره خصوصا، او المستشفيات اللي كل قسم عدد كبير من الدكاتره، انه رئيس القسم ما يقدر يسويها. فبالتالي يرجع لهذا الشخص مباشره. اذا هذا الشخص ما تعاون معه يرجع لرئيس القسم، لانه المستشفيات الكبيره رئيس القسم ما يقدر يشيل كل شيء في نفس الوقت. فهذا يعتمد من مستشفى للثاني. لكن نعم، اذا بديت بالدكتور المعالج وما نفع لازم ترجع رئيس القسم، ما نفع تروح الميديكال دايركتور. هل الميديكال ريكوردز المسؤول عنه اخصائي معلوماتيه صحيه؟ طبعا المعلومات الصحيه تخصص مهم جدا، يعني الأهمية فيه كل ما له مع الوقت تزداد أكثر. المستشفيات القديمة أو الحكومية السابقة كان اللي موجودين فيها يشتغلوا باي اكسبيرينس، بعضهم يكون تخصصهم والله دبلوم إدارة صحية، أو بعضهم حتى بدون أي تخصص، بعضهم يكون حتى تخصصات طبية بس من فترة طويلة اشتغل في الملفات، أو اشتغل في شؤون المرضى ويشتغل فيها. لكن مع الوقت حيكون في سبيشاليزيشن، خلاص كل واحد مسؤول عن تخصصه. فنعم، هو حاليا معلوماتيه الصحيه هم اغلبهم بيغطوها، خصوصا مع انتقال كثير من المستشفيات مع الالكترونيك سيستم. ترى مع الوقت الملفات هذه ما راح تكون موجوده. التعديلات غير متاحه عندما تقفل التنويم. هذا انت تقصد انه هذا شيء ايجابي ولا شيء سلبي؟ انا ما فهمت هو السؤال او لا، بس يعني انك انت تعدل على النوتس اي سلبي، اوكي. انك انت تعدل على انك انت قصدك انه لازم تعدل ولا مو لازم تعدل؟ في بعض المستشفيات يقول لك ممنوع تعدل، على اساس هم يكون عندهم القدره انه يسوي احصاءات عليها. في شيء ثاني طبعا مهم، اللي اهم منه الميديكال ليجل ايشوز. طبعا مثلا اذا انا ذكرت كذا مثال قبل شويه في الدسكشن. الدكتور اللي قال للنيرس اعطي انتبيوتيك للبيشنت، تمام، ونسي يكتب، مشيت الامور وراحت الايام، وبعدين اكتشف انه هذا البيشنت هي باست اواي بعد كم ساعه، وانه في شكوى عليه موجهه. اذا كان مسموح له هو يعدل بعدها، فبالتالي حيروح يكتب في الاوردرز ولا يكتب في النوتس، خصوصا بالبيبر ورك، انه ستارت انتبيوتيك كذا وكذا، ويحط الاسم ويختم ويمشي. طبعا هذه ديزاستر، هذه جريمه يعني. لكن لذلك هي تقفل لسبب. لكن انا اقصد اتاحه المعلومات، انك انت يكون عندك فورم زي الديشارج سمري، ما في مشكله، يو كان دو ات. بس انك تعدل على النوت، تعدل على الاوردرز، المفروض هذا يكون ممنوع تماما. وهذا خطا فادح يكون موجود في اي سيستم اذا كان متاح. لانه بكل بساطه اول ما تجي الشكوى، ابال ما يقول لك يلا روح، انت مسموح لك تراجع الملف بس ما يكون مسموح لك تكتب نوتس. تخيل ان انا اروح اراجع والقى الشكوى مكتوبه انه الدكتور ما اعطى انتبيوتيك، وانا اروح اكتب ستارت انتبيوتيك. طب انت ممكن تورط الناس كذا. فتخيل يعني، فالمفروض يكون جريمه معلوماتيه انك انت مسموح لك تسويها. اي نقطه ثانيه؟ هي حلوه فكره الكوميتي صراحه. كلمه لجنه احيانا تكون مفيده، واحيانا تكون عبء على التيم اللي موجود. لكن طالما انت عندك شيء يستدعي تعاون اكثر من قسم، لازم يكون في كوميتي. لانه الكوميتي هذه ترفع بشكل دوري. طبعا نرجع نلف ندور، نرجع على اهميه الليدر شيب رول، الهوسبيتال دايركتور. الكوميتي هذه لازم تترفع بشكل دوري، انه ايش قاعد يصير، وش الانجازات اللي سووها، وكم راجعوا ملف، وكيف حسنوا الكي بي ايز اللي فيها. فلما تكون موجوده انت تجبر. طبعا الاوديتنج طبعا مهم، التدقيق موجود. في مستشفيات عندهم اوديتنج منفصل، وفي مستشفيات يحطوها بمسميات مختلفه. الاوديتنج اللي هو يكون مشرف على الملفات هذه بشكل ما. آه اذا كان عندك سي دي اي تيم، احيانا بعض المستشفيات ما عندهم مسمى الاوديتنج، يكون عندهم مسميات اخرى. لكن لازم يكون في اوديتنج. طبعا هذه الشركات الكبيره غير الطبيه هذا شيء اساسي يعني. لكن المستشفيات لها احيانا ظروف مختلفه، بس الكونسبت لازم يكون موجود. بغض النظر اختلف المسمى، تغير المسمى، في الاخير البروسس لازم يكون موجود. تمام. فالكوميتي هذه تراجع كل شيء، تراجع المعلومات والاستاتستيك حقت اللجنه اللي هي الميديكال ريكورد، وتراجع حتى الفيدباك حق الدور اساسي موضوع الكلينيكال اوديتنج اللي موجودين. كلينيكال اوديتنج ممكن يكون يحتوي برضه نفس الشيء، يحتوي اكثر من تيم، يكون في نيرسنج دكاتره، ويكون ريبورتنج لقسم يختلف عن الميديكال ادمنستريشن، لانه يكون منفصل، والافضل انه يتبع مباشره لمدير المستشفى. هي المبادرات ترى موجوده بطرق مختلفه، لازم كل مستشفى يطبقها بالظروف الموجوده عنده. تمام. لكن المبادئ الاساسيه لازم تكون موجوده بشكل موحد. كثير اشياء تتحول لسي اي تيم بعد كل لجنه. انا ما اعرف السي دي اي تيم اللي تقصدي سلمى هو يحتوي مين بالضبط؟ مين اللي موجود فيه؟ الان الكلينيكال اوديت والريفينيو سايكل والمورتاليتي هذول مين؟ هذول السي دي اي؟ طيب اوكي، شوف هي ما في اشكاليه يعني، ترى التقسيمات الاداريه تختلف، لكن انا ارجع اكد على موضوع مهم. السي دي اي تيم اللي انت ذكرتيه هذا سي دي اي مخصص، ما يشمل الكلينيكال بارت، ما يشمل الدكاتره والنيرسز والفيزيوثيرابيست والامور الثانيه. فبالتالي يعني هو قسم مهم، بس لازم يكون في تعاون باقي الاقسام اللي تكون مظلتها الاكبر الكوميتي اللي موجوده. هذا السي دي اي تيم يكون بارت من الكوميتي اللي موجود، تمام. لكن آه، اي الوظيفه شيء ثاني، انا ما اختلف معك، لكن التاسك لازم تكون واضحه. انا ايش الحد اللي اوقف عنده؟ انا كسي دي اي تيم اسوي شيء لازم اوقف عنده. اما انك تعبي مثلا، تعبي فورمز وهذا ما اعتقد. لكن انك تسوي احصائيات وتسوي اوديتنج ما في اشكاليه، بس اهم شيء التيم يكون عدده كافي ويكونوا موجودين فيه عندهم الاكسبيرينس المناسبه. لا لانه صراحه الاوديتنج هذا قسم مهم جدا صراحه في المستشفى. طيب آه، احنا عندنا مواضيع مهمه باقيه. اعتقد عشان احنا دخلنا في صلاه المغرب الافضل باخذ ناخذ بريك. بعدين حيكون عندنا اخر جلسه، يعني ما الجلسه الاخيره حيكون فيها حنخلص كل شيء مره واحده، لكن اشكاليتنا الوحيده انه احنا ما نقدر نقفل الميتنج قبل الساعه 11، فاحنا نخلص بعد الصلاه المغرب، نخلص البارت اللي باقي لنا، وبعدين نقفل لنا الساعه 10:45. 10:45 اللي اذا في سؤال او شيء ممكن تكتبوه في البوكس، ونحن ويل ديسكس ات اجين على الساعه 10:45 او 10 ونص. 10 ونص اعتقد، وبعدين ويل كونكلود ان شاء الله. بس البارت اللي باقي لنا ما راح ياخذ وقت طويل ان شاء الله. هي مواضيع مهمه بس بشكل تسلسلي حنخلصها ان شاء الله. فمتى تفضلوا نرجع بعد صلاه المغرب؟ انا ما اعرف اذا في احد من لا في بارت بكره، بارت بارت للكودينج بكره. اخت عفاف بكره حيكون الكودينج. حيكون نفس المبدا، بس اعتقد الاوبجكتيفز اللي عندها اقل من اللي عندي. بس انا ما اعرف كم ساعه هي تحتاج. هذا موضوع ثاني، بس بنعطيكم ابديت ان شاء الله اليوم. الساعه كم حابين ترجع؟ لا احنا خلينا نتناقش اول شيء باللي باقي لنا، بعدين نشوف بكره الساعه كم. احنا اعتقد لو رجعنا الساعه 7، 7 مناسب. اوكي، 7 ولا 7 ونص، ايش رايكم؟ خلاص اوكي. الساعه 7 نرجع. وان شاء الله يكون اخر جلسه. اذا خلصنا اي وقت يصير بس يبقى البارت الاخير الكويشنز نخليها والدسكشن اخر شيء. خلاص الساعه 7 ان شاء الله. يعطيكم العافيه. السلام عليكم. طيب احنا let's continue our last parts من ال objectives today. So the next is record vital patient information using appropriate documentation tools. So electronic health record or EHR are digital version of patient paper chart and are one of the most tools in modern healthcare. EHR provide a real-time patient-centered record that makes information available on spot and securely to authorized users. There is multiple advantages in using EHR, like, as we said before, improving accuracy and clarity of medical records, reducing errors, and facilitating quick access to patient data. So the next is importance of real-life documentation. When we say real-time documentation, it refers to recording patient information as soon as it is gathered, without any delay. This practice is important to ensure that patient records are up-to-date and accurate, which in turn support a timely clinician decision-making. For example, if you document a vital signs and symptom immediately after a patient visit, it allows immediate interaction or intervention if needed at any time. And definitely, immediate documentation will avoid any medico-legal issues or consequences. So let's take an example. A doctor who reviewed a patient with sepsis in emergency department, he went immediately to evaluate the patient. He gave an order to the nurse to start antibiotics immediately. He did not write that. The patient deteriorated, and the doctor then remembered that he did not document it. And then he added the order 4 hours later. At that time, the patient passed away. So later, mortality and morbidity meeting that conducted, and they reviewed the case and the documentation written. Of course, they blamed the doctor for not charting the antibiotic earlier in the care of plan, despite he asked verbally to do it immediately. As long he did not timely document it, so it was not done. So actually, this is one of the common scenarios that is happening in clinical practice, where doctors just is instructing the nurse, just please proceed with the order. I will chart it later. And I chose sepsis as an example because this is one of the cases that every minute will make a difference in starting antibiotic earlier. So he did it. He came early to assist the patient, but he did not document it. He didn't chart it, and antibiotic was not started. So, of course, he will get the blame of this. Okay, mobile documentation tools or remote access. Mobile documentation tools, including applications or software, this was designed for like smartphones and tablets. They are becoming popular in the clinical practice, and the tools offer several benefits, such as improving accessibility to patient record. It will enable real-time updates. Maybe you will ask, if we took the previous example, if you ask the doctor, he will tell you there was no empty computer, for example, in the unit. Yes, this is happening, of course, but if you will investigate this seriously, they will not take it as an excuse for that. You have to find one and you have to do it. So if you have a tablet or a mobile documentation tools that you can, for example, your own tablet, use it in the hospital. So many hospitals, they are offering that you can access the EMR system if you are using, for example, our network, internet network. So they will make sure that you can use your computer, but without using the system outside the hospital. And at time, if you are using the application, you cannot use or access any other application other than the hospital EMR system. So I think this will help the doctor to do a real-time updates of the patient. They can streamline workflow and allow clinician to access and update patient record on the go without any delay, which is particularly useful in fast-paced environment, for example, an emergency department like our previous example, or any specialty during the on-call time where you have to act fast and without any delay. One of the other example is digital consent, as you can see in the examples. The digital consent form are another mobile tool that allows patients to sign documents electronically, making the process more efficient and secure. So with the paper system, if you are signing a consent and the consent was not found the following day, this will be a problem with the medical legal consequences of the case. But when you use this, the mobile document tools, for example, your own tablets, by accessing the hospital system, so the patient or the relative will sign, and immediately it will be uploaded in the EMR. You will find it there, and even the nurse, for example, let's say the OR nurse, she can just check before asking the patient to come to OR that already it is in the system available. Just send the patients. The disadvantages, of course, for the mobile documentation tools is the leak of information and cybersecurity, and that's why many medical centers, they are avoiding remote access to patient information. Okay, now we will move to an important topic in CDI, which is the use of improper abbreviation. The use of improper or non-standardized abbreviation in clinical documentation is a common error that can lead to misinterpretation and medical errors. While abbreviation are often used to save time, they can introduce significant risk if not universally understood or standardized. So why doctor, even from the first place, they are using abbreviation? So doctors and other healthcare professionals commonly use a list of abbreviation, acronyms, and other medical terminology as a reference to rapidly search and accurately record information and give instruction to the patient. They want to save time with faster typing due to basic services. This is all altogether considered a reason to use this. There is no standard approved list. There is no standard approved list used by healthcare professionals to search for any medical acronyms or any abbreviation. So it is important to understand the context in which the abbreviation or terms has been used. Actually, many healthcare institutions, they have their own specialized list of abbreviation that can be used. The use of medical abbreviation is not only in US, for example, or United Kingdom or any other country. It's a global problem, and it will confuse the healthcare staff. It will confuse even the health informatics people, patient affairs, even the patient themselves. Now, as you said, there is no. You can scan this and keep it for later, but there is no standardized global standardization for approved abbreviation. This is a common medical abbreviation and terms example. You can just check it later on. But the good or the way to go for approved abbreviation is to go to your hospital policy, your hospital own list. Every hospital should consider their own list, and every staff in the hospital should follow this. Even the people working in CDI should be familiar with that, and any unproved abbreviation should be considered as unproved abbreviation in the documentation should be reported. And I think in any CDI improvement project, one of the important issues that pointed and sent to the head of department is the use of unapproved abbreviation. So, for example, the abbreviation QD, which is once daily, can be easily confused with QID, which is 4 times daily. This will lead to incorrect doses and medication toxicity and side effect. So the use of non-standardized abbreviation that may be clear to one clinician, but confusing or misunderstood by others, especially in multidisciplinary team settings, such error underscore the importance to adhere to standardized documentation practice. Now, if you are using this one, QD and QID, you expect the nurses will review your order and to follow this. So if you understand your own handwriting or your own abbreviation, the other clinical staff will not be familiar with that. It's like another language. So as we said, the only way to go is to follow your own hospital practice. And many medical centers, they are even avoiding uses like QD. Instead of QD, you have to write once daily. QID, you have to use 4 times daily, or you can use Q6 hourly like this, but you should not use any abbreviation like this. Another important example is PE, which is well known to pulmonologists and most of the hospital staff as pulmonary embolism, while some cardiologists will refer PE to pericardial effusion. And if you go to urologists, they might use it for erectile dysfunction or whatever. So now this one, it will carry a serious issue because it will be misinterpreted by the clinical staff differently. So the bottom line, you have to follow your own hospital approved abbreviation. Okay, now copy-paste errors have become increasingly common with widespread use of electronic healthcare system. So while the copy-paste function can save time, it can also lead to increase to outdated or incorrect information if not carefully managed. Let's take an example of copying and paste patient information from the previous visit without updating the new finding. This one can lead to continuation of incorrect diagnosis or treatment plan. So another example is duplication of incorrect data. Maybe the ER doctor, he wrote that the patient respiratory rate is abnormal, it is 34. Patient in respiratory distress. So he started the management, the patient improved. So the patient was admitted for observation only. So the admitting team, he just copied the notes of the emergency doctor and pasted again. Then he added down on the bottom. The respiratory rate is now normal. It's 16 per minute. Patient is not in distress. He's feeling better and he's stable. So you are writing 2 contradicted data on the same note. And this is a problem medically. So as we said, a duplication of incorrect data, such as outdated or medication list. So let's take a look into a few papers regarding this issue. Here is a paper about copy-paste in EMR, and they have mentioned pros and cons about copy and paste in electronic medical record. The pros is fast and quick. You can save time with this. It's easy to use. Most people can practice it. Almost all EMR systems allow it, and it's improve efficiency, improve consistency, and ensure completeness of information. While the cons, as we said, outdated data can be transferred, must not replace the original content, but supplemented, need verification of data accuracy, which is often ignored. The source of data is often not ascertained and ignored. Risk of errors and repeating of errors in data introduce new inaccuracy and can compromise patient safety with medical legal implication and discordant notes obscuring data. Now, if the ER doctor, he wrote a wrong information, let's say he wrote that the patient has myocardial infarction in the past, and he did a cardiac cath 2 years ago, but he was referring to the next patient, not the same patient. Then this patient, he was young, he was admitted, and every doctor he is coming after ER doctor in admission, internal medicine, general surgery, whoever the team, even the supportive teams like physiotherapy, etc. They will come and write this patient known heart attack before, and he had cardiac cath. Well, it was wrong from the beginning. Everyone is copying the same note with pasting without even making sure if this is right or not. And here is another paper about sloppy and paste in patient safety network. They have mentioned a case about two issues. The first one that we have talked about is a bad abbreviation. And the second one is the overlooked copy and paste. So let's go through the case. So a 70-year-old man with hypertension and diabetes presented to the emergency department with a new onset chest pain. So the ED physician, he reviewed the patient electronic medical record and noted a history of PE listed under the past medical history section. This raised a suspicion that for a possibility of pulmonary embolus. So after initial testing, excluding a cardiac etiology, a CT scan of the chest was ordered to rule out PE. When a physician approaches the patient to explain why he was ordering the diagnostic test, the patient denied ever having any PE before or any anticoagulation for that. So after this conflicting report, the ED, he returned again to the EMR notes, and then he mistaken just a history of PE dated back several years ago. It is appeared that it was the problem list in the EMR. Investigating further back, the ED physician, he discovered that letters PE were first noted nearly a decade earlier, where it was clearly intended to reflect physical examination, not pulmonary embolism. So a physician likely copied and mistakenly posted PE under the past medical history, after which this history of pulmonary embolism was carried forward time and time again. And the patient, who was ultimately discharged from ED, never suffered any harm from the documentation error. The EMR was updated to reflect this patient never had pulmonary embolism. So as a summary of this case, we had two problems here: that the use of abbreviation, you should not use PE as physical examination. It used to be used before as physical examination, but the doctors keep copying this and paste it as pulmonary embolism. And the second one is, when you copy and paste, you are responsible for whatever you will paste in the note. So you have to make sure about the data before you are considering any information. So the conclusion here: healthcare organizations should consider implementing regular audits and feedback sessions to ensure that copy paste is used appropriately. Additionally, healthcare organizations should consider developing policy and procedures to ensure that copy pasting is used safely and effectively. These policies and procedures should include guidelines for when copy pasting should be used, how it should be used, and how it identify and address potential errors. So after copy paste, we will go to a next objective, which is the role of CDI specialist in healthcare. So as we strive for excellence in patient care, accurate and thorough clinical documentation becomes increasingly important. A CDI specialist play a vital role in ensuring the clinical records are accurate, comprehensive, and reflective of the care provided. The role of CDI specialist also to bridge the gap between clinical care and the documentation that's supported. They work closely with healthcare providers to ensure that medical records accurately reflect the patient condition, the care provided, and the outcomes achieved. This is not only enhances the patient care, but also it ensures the appropriate reimbursement, for example, and support compliance with regulatory requirements. As we mentioned, CDI specialists are responsible for a range of tasks that contribute to the overall quality of clinical documentation. One of their primary duties in reviewing clinical documentation to ensure it accurately captures the patient diagnosis and the care provided. CDI specialists also collaborate with healthcare providers, offering guidance on how to improve documentation practices. This might also include advising physicians to provide additional details in patient record to clarify this condition. In addition, CDI specialists work closely with coding teams to ensure accurate coding, to ensure the documentation accurately support the code used for billing and reimbursement, which is important for ensuring that healthcare organization just receive the payment for the service they provided. And if you are not using the proper coding, the proper documentation, that will not happen. So let's take a look to a study that illustrates the impact of CDI specialists in a hospital setting. So in this example, a CDI specialist was brought in to address an issue with documentation quality in a hospital cardiology department. So after conducting a review, the CDI specialist identified several areas where documentation was incomplete or inconsistent, particularly in the recording of congestive heart failure cases, and which will lead to many cases being rejected by insurance company for admission and to receive the proper management. So by working closely with cardiology team, the CDI specialist as an effective team to help in establishing a new template. So first of all, with IT, the CDI team, they work to have the first page about the patient information, then the provided information about the previous diagnosis or any extra information that is relevant and might change the management plan. Now in the medical history, he just rearranged it to be as yes, no, as a checklist. So any positive finding on this will be an extra positive point in approval of the admission for those cases. There is a button that for diagnosis of congestive heart failure by history, examination, radiology, and down there is an echo finding to support this one. And in every checklist the doctor will choose, it will go directly to the clinical notes with a ready template later on. And clues for differentiating between systolic and diastolic dysfunction in patients with heart failure. Again, the same checklist, just for extra information about the case. What is the goals of therapy after you completed your checklist about the case? And then the treatment guide, you will enter the vital signs, the labs, and every relevant information about the case. So here, the prospective data collective sheet. Again, there is a revision for the final important category of the management, including the level of activity and patient education. And after that, you will move to the pharmacological management. So select a drug category, and after that, there will be a general information, including the interaction, precautions, and contraindication. It will be automatically appeared in the doctor's page. And in the end, there is a congestive heart failure treatment plan, including everything and associated symptoms. So this one, it was worked out by suggestion of CDI, but with a great effort from IT team. If you are working to improve a template or to improve any project related to electronic medical records, you should have a perfect IT team working with you. As we said, it's not a one-man show. This should be one including the IT and CDI. So as a result, for the hospital, they saw a significant increase in appropriate billing and increase the number in the acceptance for admission, decrease the number in rejection. With proper template implementation, there was improvement in documentation, led to better even coordination of care, and even the quality of care was improved. So our next topic is translate medical jargon into easily understandable language in documentation. So what is medical jargon? So effective communication between clinician and patient is essential for the good care and has been shown to improve patient outcome. Plain language is essential to good communication, and yet physician and healthcare professional regularly they use jargon, technical terminology. When I say technical terminology, that a terms that is used between a specific group of profession that other people that will not understand. If you are working in a specific industry, they will use their own term that anyone outside this industry will not be familiar with that. The same is happening inside hospitals. There is a specific terminology. Some of those terminologies are medical, but some are non-medical. Let's say, for example, LOS, which is length of stay. This is the abbreviation, but at the same time, it's used by non-medical staff as a terminology that this is considered as part of the jargon that is used inside the hospital. So medical terminology is the language we all work so hard to acquire in medical school to ease the communication among members of our field, like name of the disease, for example, bronchiolitis, or organism like E. coli, or tests, procedures, drug name, and even names of the medical specialties like nephrologist. We use abbreviation and acronyms so much that some of us don't even remember the full words, such as MPO. If you ask many healthcare staff what is the full name of MPO, you will surprise that many of them they don't know. MPO, which is nil per os, which is a Latin for nothing by mouth. So commonly used this terms in patient and use the abbreviation or acronyms like CBC, ECG, CBC for complete blood count, ECG or AKG for electrocardiogram, and MI for myocardial infarction. Patients may even be unfamiliar with a term like ED, emergency department, which can have more than one meaning. While medical vernacular, which is a word that may be familiar, you will be heard in any other area, like a TV series like Dr. House, Scrub, or the other terms like febrile, sepsis, or remission, that maybe don't know the real name meaning for that by patient, but it's considered one of the medical jargon. So healthcare professionals are known for using complicated words in place of similar words that already have shared understanding. The use of unnecessary synonyms like this can lead to misunderstanding. So the importance of clear and accessible documentation. So clear and accessible documentation is essential for many reasons. To start with, to ensure the patient and their family can understand their medical condition, can understand their treatment plan, and any follow-up care they need. So the understanding is critical for patient compliance and even for positive outcome. Let's take an example. If the discharge summary is filled with medical jargon that patient cannot understand, they may not follow the plan after discharge, and they may not be compliant with medication. They will not follow the lifestyle changes that you ordered, leading to failure of treatment, leading to more readmission to the hospitals. And many medical centers, they have two documents at a time of discharge. They have the discharge summary, which is in English and with professional medical terms, and the one we just discussed in the previous part about the discharge summary, which is one of the important form. And they have another form, which is discharge instructions. It is another discharge summary, which is considered as in the patient language in a clear and uncompleted way, including the plan at discharge, the medication, instruction to the patients, and when to come to emergency to seek medical helps. And in my center, we are doing this in the other form in Arabic. So you have the full discharge summary form, and you have another discharge instruction in patient language, so it will be easy to follow, and the patient will understand the plan after discharge. Okay. In addition, clear documentation improve communication with non-clinical staff, such as case manager or social workers who may not be familiar with complex and medical terminology. So by translating jargon into plain language, we can just make documentation more inclusive and just more effective. So a common medical jargons, for example, it's important to identify the terms that are likely to be confusing for patient or non-clinical staff. Common examples include terms like hypertension instead of high blood pressure, dyspnea instead of short of breath, myocardial infarction instead of heart attack. While these terms are second nature to clinicians, we are not using these terms in our daily practice or even our clinical note, progress note, and even discharge summary. But they can be confusing to those who don't have a medical background, as we said, like patients, their families, and some of non-clinical staff in the hospital. So what strategies can be implemented for translating medical jargon? If we take an example for medical reports, so in Arab countries, many medical centers, they have the options available for the patient to get medical reports in English or in Arabic. Once the family or the patient will go to patient records or patient affairs to request for report, they will ask them, do you want it in Arabic or English? So this is one of the strategies that it's applied to make the language easier. So if they want to report for example, for another hospital or for insurance company, they will just request it in English or in medical terms. While if they want to use it for a reference or for an example, if you want it for another governmental institution, they will request it in Arabic. The other strategy, the one we just mentioned about the discharge summary, the one we discussed just earlier. So let's take a scenario. A hospital noticed that many patients were being readmitted because they were not following the discharge instruction. Upon review by a CDI team, it was found that instructions were filled with medical jargon that patient did not understand. So the hospital then implemented a new policy where another form to be added to the discharge summary, which is a discharge instruction. The discharge instruction form should be written in plain language and in patient language. As we said, in blood pressure and heart attack, another example, for example, maintaining low sodium diet. Instead, you are not telling the patient low sodium diet, you will tell the patient eat less salt. So as a result, the patient compliance improved and a rate of readmission decreased. So this is just to highlight of importance to be for clear language for the patient and to decrease any complication and improve the compliance and the patient following your order. Okay, so now we'll go to our last point to discuss today, which is effective teamwork challenges and physician or other staff arrogance. So in many healthcare settings, one of the significant challenges encountered in the proper documentation is the arrogance that some physicians or some other non-physician staff, clinical staff, they apply during the interaction with non-physician staff. So this behavior can create barriers to effective communication and for effective collaboration between specialists. So this is important for affecting the high quality of care for your patient. So if any physician dismiss the input of nurses or clinical documentation specialists or any other healthcare team member, this can lead to incomplete or inaccurate documentation. This will increase the gaps in patient care because you are blocking the job of a complete department entirely. So This could result in a serious oversight. Addressing this arrogance is crucial for collaborative environment where all teams should be contributing to the accuracy and the comprehensive patient record instead of just ignoring each other with culture of distrust. So what strategies for CDI specialists to educate and collaborate with physicians? So as we said earlier, strategies for CDI specialists. As CDI specialists play a role in addressing documentation deficiencies, even when dealing with difficulty or arrogant physicians. To start with, as we said in the previous topics, that leadership support is the manner that and considered the cornerstone to have a productive culture and relationship between the staff and the institution. If you don't have a leadership support, the institution will be the same, and the problem will go to indefinite loop without any progress. So always, if there is a problem, should be the solution should be started from the leadership support. The next step is to build a respectful and a professional relationship between the staff and the physicians, focusing on mutual goals such as improving the patient care and ensuring the accurate records. Usually, a CDI specialist can approach the physician with a collaborative manner, presenting themselves as allies other than critics. For example, instead of, let's say, directly pointing out any mistakes about the documentation, a CDI specialist might ask the physician to clarify certain documentation points to ensure that the compliance with best practice is being followed. In addition, presenting an evidence-based practice and policies during one-to-one sessions can be an effective way to educate physicians on the importance of accurate documentation. This is as we mentioned in the previous examples about the way to go with surgeons, for example, with delayed reports, or about smoking history documentation and history in clinical note. So you can approach this by head of department to approach the other physician during the morning meeting as an example. So you will discuss their input and you will give your input, and you explain the KPI target and what is requested from everyone to be followed till you reach to a mutual agreement, as we said before. So by reaching this culture with mutual respect and collaboration, CDI team can successfully engage even with most arrogant physicians and improve documentation practices and to reach to the institution goals. I think this was my last slide, and I would like to thank you all for attending today. Still, we have time, and as we said, we can delay our questions to like 10:15 or 10:30, so we can conclude our event on time. I think we don't have the ability to just conclude it now. So I believe if you have any questions or any experience you want to share or any comments, just go ahead. And I think we should meet again 15 minutes or 30 minutes before the ending of the activity, so we can have our question and answer again, and then we will conclude. So any question or comments from your side now? طيب انا اعتقد احنا will leave الشات اوبن and الايفنت اوبن، واي احد عنده سؤال من هنا الى نهايه الايفنت just write it in the chatting box. احنا will review it again. اعتقد we can meet again at 10:15. I believe that the CME's يعتمد على وجود الجميع في نهاية اليوم حسب ما وصلنا. فاحنا will meet again at 10:15. So we will conclude. If there is no question, we will conclude our meeting إن شاء الله.
السلام عليكم ورحمة الله. واضح عندكم الصوت؟ طيب. أنا السيشن قفل من عندي وما شفت الأسئلة، معلش. آه في أحد عنده أي كومنت أو سؤال حاب يسأله، أو حاب يشاركنا بأي اكسبيرينس من عنده؟ أحد عنده إضافة من الديلي براكتس اللي بيشتغل فيه وحاب يشاركنا بشيء، برضه راح يكون في فائدة للجميع، ممكن نتناقش فيها. أو اللي عنده سؤال أو شيء، الله الله يحفظكم. طيب، اللي عنده لاحقا أي نقطة تجي في باله أو شيء وعنده أي نقاش، يتواصل معي أي وقت. والله يعطيكم العافية إن شاء الله جميعا. بكرة إن شاء الله راح يتواصلوا معكم بلغوكم بالوقت، بس الدكتور اللي هي الأخت مروج السقة، هي متخصصة في الكودينج، راح تكمل الجزء الثاني. احنا الآن تكلمنا في موضوع من ناحية الكلينيكال بارت والديلي براكتس. الآن في موضوع جانب مهم جدا، لأنه أنا أعتقد كان في سؤال على موضوع تحول الوزارة. تحول الوزارة كان في جزء كبير منه ترى على موضوع الكودينج بالنسبة للبراكتس اللي موجود. فكيف نسوي الكودينج وكيف نطبقها في البراكتس اللي عندنا. انا وجهت لها السؤال، قلت انه الاودينس كان عندهم الاستفسار هذا، بكره ان شاء الله راح تكون هي مجهزه على الموضوع هذا. فالله يعطيكم العافيه جميعا، وان شاء الله موفقين باذن الله. بالنسبه للساعات، والله شوفي، انا عندي نفس الاعتراض، لكن اعتقد آه، المشرفين على كوست هم عندهم تواصل مع الهيئه عندهم شويه تعقيدات في حساب الساعات كذا. ف ما عندي اي فكره صراحه عن الموضوع هذا. لكن نعم، انا اعتقد المفروض يكون بنفس عدد الساعات، لانه في الاخير حتى يعني زي ما انت شايف ترى احنا ملزمين نجلس هذا الوقت، ولا كان خلصنا من اول يعني. لكن هم يلزموك ب 16 ساعه يعني تقديم، وفي بكره يعطوك يحسبوا لك إياه بخمس ساعات. ف انا اتفق تماما، لكن عموما في تعقيدات ثانيه بالنسبه للاجراءات. طيب، خلاص، اذا في اي نقطه ثانيه، الله يحييكم اي وقت تتواصلوا معي، وان شاء الله موفقين. يعطيكم العافيه.